Okay, so our next topic, which is the pulmonary hypertension. So when we talk about the pulmonary blood vessels, okay, and we talk about the blood pressure in them, we don't say that they're having a systolic blood pressure or they're having a diastolic blood pressure. Okay, we just measure a one pressure, which is in between 10 to 14 mm of Hg, because the vessels are highly compliant, just like the veins. Okay, so in case of pulmonary circulation, you do not measure the systolic or diastolic blood pressure, but you maintain, you just measure one pressure, which is this one, okay, the 10 to 14 mm of Hg. Okay, you will call it a pulmonary hypertension when this pressure rises more than 25 mm of Hg. Okay, this can happen ultimately, this can lead to the atherosclerosis, this can lead to the medial hypertrophy, and this can ultimately lead to the intimal fibrosis. So when you encounter a patient who is having a pulmonary hypertension and you do the biopsy of their vessel, what you will find is the atherosclerosis in the vessels. You will have a medial hypertrophy because whenever you have a high blood pressure, the blood pressure, these vessels, will try to maintain it. Okay, they will try to, compensate for that. So they will undergo this hypertrophy. So you will be having ultimately the hypertrophy. Finally, you will be having an intimal fibrosis. You have 3 layers in the, in the arteries. Remember the tunica media, externa, and intima.
Yeah.
In the tunica intima, which is the innermost endothelial layer, you will be having a fibrosis in it. Now, see, initially what happens is, if this is your normal vessel, you will have some plaque formation because of a hypertension in it. After this plaque formation, you will have a thickening of the tunica media, which is the medial hypertrophy, right?
Yes.
After this, as a result, because of this medial hypertrophy, the lumen will become very narrow. Okay. Now, after this, fibrosis of this tunica intima will be started. Okay, you'll be having a fibrosis ultimately in the tunica intima. If this continues even more, if this hypertension is continued, then what will happen? These fibrosis will form some plexiform lesions, and small lumens will will be formed within this large lumen. So this lumen will undergo the fibrosis diffusely. Okay, there's a diffuse fibrosis happen in the lumen, and some areas will be remain without the fibrosis. So small lumens will be formed within a large lumen, and you will call it a plexiform lesions. Okay, so these are the changes that will take place whenever a patient is having a pulmonary hypertension. Is that okay with everyone?
Yes.
Ultimately, the patient would be having a severe respiratory distress, cyanosis. Because of this high blood pressure in the pulmonary arteries, patient will undergo this right ventricular hypertrophy, right?
Yeah.
And that causes the right-sided heart failure in the patient. And please note, this fibrosis, hypertrophy, plexiform lesions, they are always irreversible. Okay, once you develop them, there's no going back. So you have to prevent the condition before all of these changes developed, right?
Yeah.
Same thing will happen if you got a right to left shunt, if you guys remember. Right to left or left to right shunt? Left to right shunt, right? When you got a left to right shunt, you will be having a pulmonary hypertension, and then you develop the acute pulmonary because of that. I remember what syndrome is known as?
Eisenmenger.
Yeah, the Eisenmenger syndrome you will develop. And again, in case of this syndrome, you will get an irreversible fibrosis in the lungs, irreversible changes in these vessels in the lungs, right? So these changes are always irreversible type. Okay, any doubt so far?
No, thank you.
Now let's discuss the causes. You have a primary cause. That means idiopathically patient develops this hypertension in the lungs without any specific cause. Or it could be secondary from, it could be due to any heart disease, left heart disease. It could be due to a hypoxic vasoconstriction. It could be due to a thromboembolism, or it could be due to other etiology, and you will call it a secondary pulmonary hypertension. So for the pulmonary hypertension, which is a primary type, it will always be seen in a young female patient. Okay, so a young female patient who is having a dyspnea and all these things, respiratory distress, fatigue, shortness of breath. Okay, a very young patient. See, whenever you encounter a patient having all this respiratory disease or fibrosis, it will always be an old age patient, right?
Right.
a young age patient won't develop these symptoms very easily. So if you encounter a very young female patient who is having a respiratory distress, you can think about this pulmonary hypertension. Okay, it happens because of an inactivating mutation in the BMPR2 gene. Okay, and as a result, the function of this gene is to inhibit the proliferation of the smooth muscles in the vessel. So now, because this gene is not inhibited, okay, your vessels will undergo the hypertrophy, and you will have all these changes which I've mentioned here, right?
Right.
So apart from that, the vasoconstrictors will be increased and the vasodilators will be decreased. So one of the major vasoconstrictors is the endothelin. Okay, this endothelin will be increased, and the vasodilator, which is a nitric oxide and the prostacyclins, they will be decreased, right?
Right.
So these changes will be there whenever this kind of a primary hypertension. So if you encounter a patient who is having a shortness of breath, fatigue, and dizziness, maybe dyspnea, okay, with the exercise, okay, and if you perform the X-ray in this patient, you won't find anything. X-ray will be absolutely normal, okay, and that's how you know patient is having a pulmonary hypertension. So always be a young female, okay. Now, other than it can happen with with the drugs also. If you take a sympathetic mimetic agents, okay, the sympathetic mimetic agents, for example, the amphetamines, cocaines, they can they can do that. Okay, any kind of a connective tissue disease can do that. Okay, if the patient is having a HIV, he can develop this hypertension. The portal hypertension can ultimately lead to the pulmonary hypertension. Okay, and other any kind of a congenital heart disease can do that. Okay, schistosomiasis can also do that. So these are the causes of other causes of this pulmonary hypertension. Is that okay?
Yeah.
Now, other two important one, which is not mentioned here, which is basically the MSK. I told you about the rheumatoid arthritis, right?
Yeah.
The patient with rheumatoid arthritis can also have a pulmonary hypertension. Second one important, I also told you, if anyone remember, in the musculoskeletal.
Scleroderma.
Yeah, scleroderma. You can have, scleroderma. Systemic sclerosis you will happen in this condition. If you're having a systemic this scleroderma type thing, then you will end up having a pulmonary hypertension again, right?
Yeah.
So these are all the causes of a primary pulmonary hypertension. Okay. And please note that treatment includes giving the patient vasodilatory agents that can decrease the blood pressure, and that include the bosentan, sildenafil, and the apoprostenol. Okay, we will discuss these drugs later, but just for a treatment purpose, know these drugs. Okay, so these are three important drugs which will which will treat this pulmonary hypertension. Okay.
Yes.
Now, second one is the left-sided heart failure. If you got a left-sided heart failure, all this pressure and the fluid will get backflow in the lungs, right?
Yeah.
And ultimately, you will end up having a pulmonary hypertension because of that. If you got no air in the alveoli, hypoxic pulmonary vasoconstriction will happen, and that can again lead to the pulmonary hypertension. So that can happen because of the COPD, because of a lung fibrosis, for example, the interstitial lung disease, because of a hypoxic vasoconstriction that includes the obstructive sleep apnea or living in a higher altitude. So these patients will again have a pulmonary hypertension, right?
Yeah.
Findings again will be same. The patient will be having a dyspnea, shortness of breath, okay, and exercise intolerance. But in case of your left-sided heart disease, you will also have a X-ray findings, right? X-ray will show the edema, right?
Yes.
Similarly, in all these diseases, in COPD, in interstitial lung disease, you will again find the X-ray thing, showing these opacities in the lungs, right?
Yeah.
So again, X-ray will be positive. So if the X-ray is normal, think about the primary type. If the X-ray is not normal, think about these other types, right?
Yes.
Chronic thromboembolism, if the patient is having a recurrent microthrombitis in the vessels, that can again lead to the pulmonary hypertension. Okay. Some metabolic causes, hematologic causes, multiple tumors can do that. So these are the multifactorial causes of the pulmonary hypertension. So symptoms are just fatigue, shortness of breath, and exercise tolerance. X-ray will help you, biopsy will help you, and the patient history again will help you. A young female patient having a shortness of breath and this fatigue and exercise intolerance, you can think about the primary type. If the patient is having a old age patient having some X-ray changes in the lungs, edema maybe, or reticular opacities, you can think about other causes. BP is always more than 25 mm of Hg. Complications, they can ask you. Findings about these vessels, they can ask you. Okay. So these are all the questions which could be framed on the pulmonary hypertension. So any doubt, please ask.
No, thank you.
Okay. Now, what about the PCWP in case of the primary pulmonary hypertension? Would it increase or would it decrease? Or would it remain normal?
Normal, I think.
Okay, anyone want to try?
What is it, please? I think it's normal.
What about normal? Okay. Anyone other want to try? Any other vote against it? Come on, try. No one? Okay, so see, what's going to happen is, because of this primary pulmonary hypertension, do you having a decrease in lumen size?
Yes.
So if the lumen size is decrease, what about the blood flow? Increase or decrease or normal?
Decreased.
Decrease. Now, you're having a pulmonary hypertension. Does it putting an extra load on my right heart?
Yes.
So imagine the left heart. If I increase the afterload of the left heart, what about the cardiac output? Would it increase or decrease?
Decrease.
So what's going to happen here? Because of pulmonary hypertension, the cardiac output of my right heart increase or decrease?
Decrease.
Decreased.
So if the less blood is flowing from my right heart to left heart, what's going to happen to the PCWP now?
Decrease.
Decreased. PCWP will be decreased in case of pulmonary hypertension because of obstruction of the blood flow from right side of heart to the left side of the heart, right?
Okay.
So again, one more thing, because the patient is undergoing a right ventricular hypertrophy, these patients become susceptible to develop the angina also, right?
Okay.
Because if the wall is getting thickened, then your subendothelial layer will become hypoxia, right? Hypoxia will happen in subendothelial layer, right?
Yes.
So again, these patients will develop the angina also. So it could be a only the stable type of angina. Whenever the patient exercises, they will have this chest pain. Syncope can happen because of loss of cardiac output, exercise intolerance, dyspnea, fatigue, right? All these are symptoms of the pulmonary hypertension. What about, one more thing I forgot to tell you. What about the heart sound? You have, the S1 heart sound and the S2 heart sound. In the S2 heart sound, it could be A2 and could be P2, right? It could be due to closure of this aortic valve or could be due to a closure of pulmonary valve, right?
Yes.
Can you find a delayed P2?
Yes.
So you will have a delayed P2 and that will increase the difference between the A2 and P2 time. So what will you call it?
Wide S2
Split. Yeah, you will get a wide S2 split, right?
Yes.
So this is again very important. You will get a wide S2 split, this S2 split. And what about the heart sound? Would this heart sound increase or decreased?
Increased.
Increased.
Yes.
Okay, good. Okay, so you will have a very loud P2 because of this increase. See, this P2 sound will occur whenever the valve closes, and that happens whenever the pressure in my artery is more than the ventricle chamber, right?
Right.
So now, because you're having already pulmonary hypertension, pressure is so much high in the lungs. So this will cause a forceful closure of a pulmonic valve. Okay, and that forms a very loud sound, right? That produces a very loud sound. So a very loud P2 will be there with a splitting. Okay, so delayed P2 with loud P2. This is again a finding you will see in case of primary pulmonary hypertension. Okay,
Yes.
so this will help you determining the cause of this right ventricular hypertrophy. If the patient is having a stenosis in the pulmonic valve, then this sound will be lost completely, right? You will have a very faint sound or no sound at all. But if you're having very loud P2, that means this hypertrophy is due to a hypertension in the lungs. Okay, remember that also. So any doubt on this page anywhere?
No, thank you.
Will there be peripheral edema, lower limb edema, or jugular vein distension and pulmonary hypertension?
Because of right-sided heart failure.
Sorry.
If ultimately you're having a right-sided heart failure, so what symptoms would you get? Backflow of the blood in all the veins, right? Jugular veins, superior vena cava, inferior vena cava.
So that's as a sequence, but not as a
Yeah. No, yeah. Yeah, it is sequel of this this hypertension, okay?
Okay.
So that we have discussed already about the OSA and the Cheyne-Stokes respiration. You will get a normal muscle function, normal nerve function, but apnea these episodes. But in case of central sleep apnea, you will get a loss of muscle function, loss of nerve function, and then you will get the apnea. Morbidities are very important. Heart failure case will be there, injury case will be there, herniation case will be there. But if only obesity is present, you will only think about the OSA, not this Cheyne-Stokes respiration. Now you have some other diseases. First one is the pleural effusion. Second is the atelectasis. Pneumothorax, which could be simple type or tension type. Consolidation, that could be due to any kind of a fluid which is filled in your lungs. So how we differentiate on the examination whether the patient is having a effusion or consolidation or pneumothorax or atelectasis? So in case of a pleural effusion, you're having the pleura filled with excessive fluid. Okay.
Yes.
In case of atelectasis, you will be having a collapse of the airways. Okay, you will be having a collapse of the alveoli. Okay.
Yes.
In case of pneumothorax, this pleural space will be filled with the air. Okay, and in case of consolidation, the lungs itself, the parenchyma, the alveoli, airways, they will be filled with the fluid.
Yes.
Okay, so let's discuss how we differentiate between all these conditions by by examining the patient. Okay, the first one is the breath sound. Now, because whenever you have a fluid, it will insulate the sounds, right?
Right.
So it will become very harder to to hear them. So as a result, if you're having a fluid, that means in case of your this effusion, the patient will have a decreased breath sounds, right?
Right.
Second thing, in case of atelectasis, again, because the air is not, all these alveoli, because they are collapsed, the air cannot enter into the alveoli.
Yes.
So no air means no breath sounds. Again, sounds will be decreased. In case of pneumothorax, because of presence of air in your, in the pleura, ultimately it will be compressing the lungs. And when the lungs got compressed, less air can enter into the lungs.
Yes.
Again, loss of breath sound. In case of consolidations, your lungs become hardened and sounds can easily travel in the solids than in the liquids and gases. Okay.
Yes.
Now, because of this consolidation and all these sounds can travel now easily, patient can have a bronchial breath sounds. The sounds will be increased. Okay. Other than that, patient on the auscultation can also have a crackles because you're having an edema in the lungs. And how does a crackling sound produces?
Opening of the alveoli.
Yeah, because of this presence of this protein-rich fluid, the alveolus can they can be collapsed down, right? So this can again produce the crackles because you have a forceful opening of these alveoli. Okay, and esophagony will be present, egophony will be present. When you ask the patient to to speak up E, this E will appear as a on the auscultation. Okay, so this thing can again also be present. Now the percussion. When you percuss the patient on the effusion, you will have, because of this presence of fluid, you will have a very dull percussion. In case of atelectasis, because the lungs are now collapsed, you will again be having a dull percussion because ultimately the density will be increasing in the lungs, right?
Right.
So whenever the density is increased, dull percussion will be formed. In case of pneumothorax, because the air is present, the percussion becomes hyper resonant type. Okay.
Yes.
And finally, in case of consolidation, again, because of fluid is present in the lungs, what you will have is the dull percussion.
Yes.
Okay. Now comes the firmitis, that means the vibrations. Okay. Now, in case of pleural effusions, this vibrations in the lungs will be decreased because of a fluid present. In case of atelectasis, because all these alveoli are not getting collapsed. Just give me a second. Okay. Yeah. So for pseudophthirmitis, see, in case of effusion, the vibrations because of presence of fluid will be decreased. In case of atelectasis, because the lungs are not getting compromised, they're getting collapsed, you will be having a loss of vibration again. In case of pneumothorax, the air is filling between the pleural space and they will be compressing the lungs. Again, loss of vibrations will be seen. But in case of consolidations, vibration can easily travel in the solids. So you will be having a very high vibration. So phragmitis will be increased in case of consolidation while decreased in all of them. Now comes the tracheal deviation. Whenever the pressure on one side of the lungs is increased, it will cause the deviation of the trachea, right?
Right.
So if the pleural effusion is there, if the pleura is filled with the fluid, they can cause a deviation of the trachea. Okay. If a pleural effusion is very small, it won't cause any kind of a deviation. But if it is large enough, it will deviate the trachea away from the lesion. If this effusion is on this left side, patient will get a deviation of trachea oppositely, means on the right side, right?
Yes.
This thing will be there. In case of atelectasis, because the airways are getting collapsed. Okay, the size of one lung is not decreasing because of this collapsing thing. So trachea will deviate towards it, right?
Right.
So in case of atelectasis, towards the side of lesion will be there. In case of simple pneumothorax, you won't have any deviation. In case of tension pneumothorax, because the pressure in one lung is increasing, this will deviate the trachea away from the side of lesion, right?
Yes.
So away will be there. In case of pneumonia, you won't have any change in the pressure mainly, so no deviation will be there. So these are the examination that you must perform whenever you encounter a patient having a shortness of breath and crackle sound and all these things. Okay. If you encounter a patient having a loss of breath sounds, you will think about the effusion, atelectasis, and pneumothorax. Then you move forward. You check for the percussion. If the percussion is hyperresonant, then simple thing, you will be having a pneumothorax. If you're having a dull percussion, that means it could be effusion. It could be the atelectasis. Then you check for the vibration, and this will be same in both of them. But if you're seeing the tracheal deviation towards the side of lesion, that means atelectasis. If away or no deviation at all, that means the effusion, right?
Yes.
So that's how you differentiate between the different conditions. So we'll discuss all of these conditions one by one now. So, but for the examination purpose, all of these things will be performed. Any doubt, please ask.
No, thank you.
Now see, whenever you have a air in your lungs, in your pleura, okay, you will having a loss of density of the lungs, kind of, right? And that is causing the hyperresonancy on the percussion. So can I say a COPD patient, a emphysematic patient can also have this hyperresonancy on the percussion?
Right.
Okay, so remember this thing also. They can give you a patient having a hyperresonant percussion. So don't just jump for the pneumothorax. Look for other symptoms also. Look for the lung size. Look for the EP diameter, chest X-ray finding, this hyperinflation, all these things. Then only, if these things are not present, then only jump for the pneumothorax. If the smoking history is present and all these things are present, go for the emphysema. Okay. Are we good here?
Yes.
Yes.
Yeah.
Okay, so yeah, that was about it. One more thing, let's discuss about this pulmonary edema. See, whenever you have an edema, okay, it happened when the alveoli and the interstitium of the lung is filled with the fluid, right? That could be happen because of a heart failure, maybe. Yes.
Yes.
So the step one can also ask you one thing: why this edema is happening in case of heart failure? Okay, so that's happening because of an increase in the hydrostatic pressure, right?
Right.
So in case of pulmonary edema, the alveoli will filled with the fluid, and that's because of an increase in hydrostatic pressure. So it will be a transduative type of fluid. Okay, it is more like watery kind, not a protein rich. Okay.
Yes.
Now all this fluid will enter into the interstitium, which is basically basement membrane, and all this space present between the different alveoli and blood vessels. So this fluid will enter there. This fluid will enter into the alveoli also, and this will cause a decrease in the gas exchange, right?
Yes.
But I told you that the CO2 is exchanged about 10 times more than the O2, right?
Yeah.
So the CO2 exchange in these patients will be totally normal, but the O2 level in the patient will be decreased, right?
Okay, yeah.
Yes.
So look for this thing. Step 1 can trick you into this. They can ask you about the CO2 levels and the O2 levels in a patient having a pulmonary edema. Okay, because you must just think about it. In case of edema, ultimately you'll be having a diffuse thickness of this barrier, of this diffusion barrier, and that won't affect your this exchange of CO2 much. Okay, so CO2 levels will be absolutely normal in these patients, but they just cannot exchange the oxygen anymore. So hypoxia, that's why. Versus in case of alveolar hypoventilation, if you get a complete collapse of the alveoli, or you got some kind of a blockage that is preventing the air entering into the alveoli, only then you can have a loss of oxygen as well as increase of CO2 in your body, right?
Yes.
So look for this thing, very important. So let's discuss other conditions. The first one is the atelectasis, okay, and that is a collapse of the alveoli, okay. As you can see here, there is a collapse of the upper lobe of your right lung, right? Now see, let me draw something for you. If this is your right lung, okay, and you have three lobes, you have two fissures, the horizontal one and this oblique one, right?
Yes.
Now when you have a collapse in this upper lobe, because of this collapse, this when this upper lobe is collapsing, what will happen to this fissure? Would it remain horizontal or would it change like that?
It'll bulge.
Yeah, exactly. So what will happen, as you can see, you're having a right upper lobe collapse, but as you can see, this line is present demarcating, if you get appreciate that, right?
Yeah.
So this was a horizontal fissure that now become oblique because of a collapse of this upper lobe.
Yes.
Okay, so this thing is always present. Change in the direction of these fissures will be there. Okay, so look for this condition also. So that was the alveolar collapse you will see. So when the alveolar got collapsed, it will also pull the viscera apart from that, right? The viscera will also be pulled up, with them, right? So the pleura, the viscera, okay, and the trachea,
Yes.
all these structures which are present in, or surrounding that area will get pulled along with that also. So this will cause a tracheal deviation. This will cause the deviation of your, all these fissures also, right? All these, the pleura also, okay. So ultimately, because of a collapse, the air cannot go inside the alveoli. If the air cannot go inside the alveoli, you will end up having a loss of oxygen and more carbon dioxide, right?
Right.
What about the findings on the auscultation? You will get the inspiratory crackles because now you have to forcefully open the alveoli whenever they get collapsed, right?
Yes.
So auscultation findings suggest, you will be having. Yeah, so on the auscultations, you will get the inspiratory crackles. Apart from that, on the X-ray, what you will see, because of a collapse of this complete lobe, you will see a complete whiteout in one lobe, right?
Yes.
Yeah.
Okay, you cannot appreciate any air density in this area because this area is totally collapsed. So a complete whiteout will be seen. That is again a very important thing. Okay, so these are the X-ray findings in the patient. Auscultatory finding and examination findings we have discussed already. You will have a loss of breath sounds. You will have a very dull percussion. You will have a loss of vibrations, and the trachea will be on the X-ray. You can even see that the trachea is pulling towards the side of this whiteout, right?
Right.
Now let's discuss the causes. It could be due to obstruction. Whenever something is obstructing the airway passage, it will prevent the air from entering into the alveoli, and as a result, alveoli will get collapsed because of that. It could be a foreign body, it could be a mucus plug, it could be a tumor from your bronchial epithelium, right?
Right.
Second thing is the compressive type. Whenever an external force is there that is compressing the lungs, it could be due to the pleural effusion, for example. It could be due to a mesothelioma. I told you, whenever you have some kind of a mass over your lungs, it will compress them, right?
Right.
Any kind of a space occupying lesion can do that. Okay, so these are all the causes for the compressive type of atelectasis. Now, third one is the contraction type, and that happens whenever you got an inflammation. Sorry, scarring after the inflammation. You got an inflammation, and after that, the healing happens with the fibrosis. Okay, or you get a fibrosis in the lungs somehow. So this will cause a contraction type of atelectasis. So whenever you have a fibrosis in the lungs, okay, think about the contraction type. It can happen in case of sarcoidosis. So any kind of a chronic destructive process, any kind of a fibrosis can do the contraction type of atelectasis. Other one is called the adhesive type. Okay, it happens whenever you got a collapse of alveoli because of protein-rich fluid. For example, the ARDS, NRDS, right?
Right.
So NRDS in the babies, okay, and loss of surfactant, for example, this loss of surfactant can happen in the babies, NRDS can happen in the adults in case of ARDS. So these are the causes. Adhesive type, okay. Post-operative atelectasis can also happen. Okay, it generally happens, as the name suggests, whenever a patient undergo any kind of a surgery. Shortly after the surgery, they develop this respiratory distress, they develop the atelectasis. We will call it a post-operative atelectasis. Okay, and this is it. Yeah. So whenever you got an acute inflammation, and that's exactly happening in case of ARDS and RDS, you will get an adhesive type. When you got a chronic inflammation, that means or this fibrosis, you will get a contraction type. In both these conditions, you're having inflammation, right?
Yes.
But one is the chronic and one is the acute. In the acute type, adhesive. In the chronic type, contraction. So AACC. Again, this will help you remembering these things. Compressive type, external force is compressing. Could be a effusion, could be a tumor, could be any kind of a space occupying lesion can do that. Obstructive type, you'll be having obstruction in the airway. Okay.
Yes.
So now tell me, when this airway is getting when this lungs is getting collapsed, what will happen to the intrapleural pressure?
It'll become more negative.
Yeah, it will become more negative. So you will have a rapid decrease in the intrapleural pressure. You can say a rapid, this more negative intrapleural pressure. Okay.
Yes.
So this again thing, because you're having a pulling of this visceral pleura away from the parietal pleura, and if they pulled much, then you will have a more negative pressure, right?
Right.
So this thing again will be seen. A rapid decrease in the intrapleural pressure you will find is present in these patients. So any doubt about this atelectasis?
No.
Repeat. What would happen
Yeah.
if pressure becomes more negative?
What will happen if pressure becomes more negative? Well, not just significant, symptoms won't happen much. See, most symptoms are because of atelectasis only, right?
Yeah.
So really, it just, I really don't know what happens is they become more negative.
No. You said that what will happen, like
Yeah.
last line that you have just said. I missed it.
The pulling of visceral pleura from the parietal pleura.
I don't
That
know.
line?
You were just maybe that line.
See, what
will
happens is
happen?
when the lungs are getting collapsed, they will pull this pleura away from the parietal pleura, right?
Okay.
So I told you this negative pressure is because whenever you have this, the pulling of the pleuras away from each other, right? So when you have more pulling, more negative pressure. When you have less pulling, less negative pressure, right? So
Yeah,
because
yeah.
in this case, the lungs are getting, these lungs are pulling the pleura away from each other, so they will cause more negative pressure. So you have a decrease in the pressure, right? A rapid fall in the intrapleural pressure will be seen. Okay. Is that your question or something else?
This is what I want to hear. Thank you.
Okay. Okay, so any more doubt on this atelectasis thing?
No, thank you.
So please remember about this PO2 level and the PCO2 level. You know, this is the side where they can trick you in any of these conditions. So you have to be very careful while picking the options for CO2 and O2. Okay, just think about this barrier, diffusion barrier. Think about the fluid presence or not. Think about the obstruction of the airway or not. Okay, if the collapse is there, no air can enter, and ultimately you will be having a loss of O2 and more CO2. If the alveoli are kind of normal but filled with some kind of a fluid, or this barrier is getting thickened, in that case O2 will be decreased, but the CO2 will be kind of normal. Okay, now you have the pleural effusion. Okay, when that means you're having a more fluid in the pleuras. If you have more fluid in the pleuras, that can again lead to the atelectasis, right?
Right.
So other thing that these can do, see, whenever you encounter a patient having a pleural effusion, this pleural effusion will prevent the expansion of your lungs, right?
Yes.
Again, these patients will be having the shortness of the breath. These patients will be having a shallow breathing, rapid breathing, just like a normal this residual disease. Yes.
Right.
Yes.
Now, if you perform the X-ray on these patients, because this fluid is under the influence of gravity, so you see when you take the X-ray of a patient on the standing position, upright position, you will have this fluid present here, right, in the lower lobe. So it will always be shown you with a complete whiteout in the lower lobes, right?
Right.
That is the first thing. Now, second thing, you have the demarcation lines for the diaphragm also. As you can see, you cannot appreciate a diaphragm here, right? The angle of the diaphragm is now lost.
Right.
Okay, so this again thing will be seen. You will have a loss of angle of this diaphragm. Okay, blunting, you will say a blunting of the costophrenic angle will be there. You will call it. Okay.
Okay.
Okay, this costophrenic angle, which was very sharp initially, it become very much blunt because of presence of this fluid in the lungs. Okay, so this is again a finding. So you cannot appreciate the diaphragm on one side wherever the fluid is present. If the fluid is under this influence of gravity, as you can see, when the patient is on the lying position, the fluid is here, right?
Yes.
This is a fluid, as you can see on the CT of the patient. This is a fluid. These are the airways, your lungs, and this is a fluid, right? So this fluid is always under the influence of gravity. It's kind of a mobile fluid. If the patient is in the upright condition, it will be affecting your lower limbs, lower lobes. If the patient is in the lying position, it will affect the posterior part of the lungs. Okay, and you will have the X-ray accordingly with that. Now, important thing are the causes. Okay, examination, I told you already, you will get a loss of the breath sounds. You will get a dull percussion. You will get a loss of tactile firmities. You will also get a away from the side of lesion, the tracheal deviation, right?
Yes.
So these are the findings you will see whenever you encounter a patient having a pleural effusion. Now, this fluid could be of three types. It could be a lymphatic fluid. It could be a exudative fluid. It could be a transudate fluid. Okay. The lymphatic fluid will be there whenever you have a damage of the lymph node or a lymphatic vessel, right?
Right.
And that can happen with the head and neck surgery or the thoracic surgeries. Whenever you somehow damage the thoracic duct, and whenever this thoracic duct got damaged, you will have a leakage of the fluid inside the pleural space, and that causes the lymphatic type pleural effusion. Okay, so remember the neck and thoracic surgeries are mainly that can cause this condition. Again, other thing as the malignancy. With the malignancy, when you have the blockage of the lymphatic vessels, that can cause a lymphatic type of fluid, right?
Okay.
Okay, so these are the causes for the lymphatic type of pleural effusion. The important findings, because whenever you see this patient having a pleural effusion, you need to aspirate that fluid. You need to check whether the fluid is lymphatic, exudate, or transudate. Okay, so you look for the triglyceride level, and what you will find in the lymphatic fluid, it will be having a very high count of triglycerides. Okay, so a high triglyceride count is present, and because the triglycerides are very high, you will be having a milky appearance of this fluid, right?
Right.
So on the removal of fluid, if you see the fluid is having a very milky appearance, okay, and the fluid is having a very high triglyceride count, that means this tissue must be lymphatic type, and that means there must be some kind of a damage happen to the limbs, or maybe it could be due to any malignancy. Okay.
Okay.
Yes.
I just need 1 second. Now, does anyone know, we are discussing all this effusion and all these things. Does anyone know how this pleural fluid is formed? Normally, because normally you have some kind of a fluid in a pleura, right? How does this fluid is forming in the pleuras?
Ultrafiltration
Ultrafiltration by what?
of the blood
Blood in which vessel?
in the pleural vessels.
What are the pleura vessels? You have blood vessels in the pleura, you're saying?
Yeah, in the pleural membranes, I mean.
No. Anyone?
Of pleura.
What?
I think it's a balance of
Balance.
these forces in the capillary bed,
What capillary bed?
the pulmonary capillary bed, where the filtration is going on.
Okay, so let's discuss this. Okay, for that, let me open a file, because we're studying the effusion, but we don't know how this fluid is forming, right, in the first place. So we need to understand that first, right?
Okay.
Yes.
So let's open up a file. Okay, see, you have two vessels. One is the bronchial vessels, okay, and second is the intercostal arteries, okay, that are present in the intercostal space, right?
Yes.
The majority part of this fluid, this pleural fluid, is contributed by the intercostal vessels, while the minority part is contributed by these bronchial vessels. Okay, and other vessels you have is the pulmonary capillaries also, right?
Yeah.
So some part can also be contributed by the pulmonary vessels also. Okay, so three things. One is the intercostal vessels, second is the bronchial vessels, and third is the pulmonary vessels itself. See, majority of the part is contributed by the intercostal vessels, while the minority of part is contributed by the bronchial vessels and the pleural vessels. Okay, when this fluid is got filtered from them, it will taken up by the lymphatics. So you see, if you're having a damage in the intercostal vessels, you can have more fluid.
Right.
If you got a backup of fluid in your pleural, these arteries, then you can have a more fluid leakage.
Right.
If you got a blockage in the lymphatic drainage, then again you will get a more fluid.
Right.
Okay, so see, in normal scenario, the majority part is contributed by the intercostal vessels, but in case of a heart failure, the majority part is contributed by the pulmonary vessels, right?
Right.
So remember this condition also. Now, pleural effusion can also be known as the parapneumonic effusion, okay, which is around the lungs. That means para means around, pneumonic means lungs, right? So this is a fluid around the lungs. So sometimes step one can also mention this parapneumonic effusion. So don't get confused. Both are the same things. Okay.
Yes.
Now you guys know how this fluid is formed. Okay.
Yeah.
So if you somehow got a blockage in the lymphatic vessels, you will get this fluid again. Okay. So now let's discuss the lymphatic causes first. Because of a damage to the lymph vessels directly, you can have a loss of lymphatic fluid. This will enter the pleural phase and you will get the lymphatic type of pleural effusion. Now, second one is the exudative type. Okay. In the exudative type, it happens because of a damage to the capillary vessels. And as a result, you will have a leakage of fluid from the capillaries. Okay. And please note, you will have a very high protein content in case of a exudative type of fluid. And it happens mostly because of inflammation. Because with the inflammation, you will have a damage of the endothelium, right?
Right.
And that will cause a filtration of all this fluid and the proteins. Because normally, in case of filtration, you won't have the filtration of proteins. Remember, albumin is there to prevent this condition, right?
Right.
So in a normal filtration, you won't have proteins, but you're getting too much of the proteins. That means the endothelium is getting damaged. And now proteins even can be leaked, right?
Yes.
So this can happen because of any malignancy. This can happen because of an inflammation, like an infection could be a pneumonia case. It could be happen because of a collagen vascular diseases. It can happen because of a trauma. Okay. And when you check for the levels, you will have a very high protein count. You will be having a very high LDH count. LDH is a marker of cellular destruction, remember?
Yeah.
So LDH count will be high, protein count will be high, glucose will be very much low. That is again important thing. Okay, and that makes the fluid exudative type. So if you're having a protein more than 50% of normal, if you're having a LDH more than 50% of a normal plasma, see if you're having a this protein count, for example, 100 in the plasma, and you get up in this protein count in the effusion is around 60 or 70, then you know that this condition is exudative. Similarly, if you're having a LDH count of 100 in the plasma and you're having a LDH count in this fluid is around 70 or 80 again, you will immediately know that this condition is because of an exudative type of fluid, right?
Right.
So more than 50% of exudate this protein and more than 50 or 60% of this LDH, this will make this fluid a exudative type. Okay.
Yes.
So remember, any inflammatory cause, any infectious cause can do that. Now, if you're having a normal bacterial type of infection, in the exudate, you can also find the neutrophils, right?
Yeah.
But if you're having the effusion because of tuberculosis, then instead of the neutrophils, you will find the lymphocytes there.
Okay.
Okay. Again, this type one can ask you this fact, that what kind of a cells you can expect in case of a patient having the exudate type of effusion. So in case of TB, it must be the lymphocytes, while in case of my any normal pneumonia, it will be the neutrophils. Okay.
Yes.
Now the other type of fluid is a transudative type, and it happens because of an increase in hydrostatic pressure. Permeability is totally normal, but the hydrostatic pressure is now increasing. And I told you, whenever you have an increase in the hydrostatic pressure, that can lead to the exchange of fluid more, right?
Right.
So you won't have any cell in that because cells cannot cross this barrier. Proteins cannot cross this barrier, or a very slight protein can cross. So the protein count is always less than 60%, opposite to that of criteria we discussed previously, right? Protein less than 60%, LDH less than 60%. Okay, having a normal LDH. Okay, no WBCs will be seen. It happened because of an increase in hydrostatic pressure that could be due to a heart failure. It could be a sodium retention, because whenever you have a sodium retention, you will have more fluid, right?
Right.
It could be due to a loss of proteins also, maybe due to a nephrotic syndrome, maybe due to a cirrhosis. So all of these conditions will be decreasing the, either increasing the hydrostatic pressure or decreasing the amniotic pressure, right?
Yeah.
And whenever you see, this fluid, it will be always a straw colored fluid. Okay, very important. And you can also have a monocytes, and these are the normal fluids. These are normal findings. Okay, some number of monocytes could still be there, and that is totally normal. So if you encounter a patient having a straw colored fluid from the lungs, you're extracting a straw colored fluid from the spaces. That means it is a transudative type. If you're extracting a milky white fluid, that means it is a lymphatic type. Okay, a cloudy type of tissue, this fluid, yellow colloidy, that means it is a exudative type, right?
Right.
So these are all the causes of the pleural effusion. Now see, again, very important concept. Normally, when you have this exudative type of pleural effusion, would it be infectious or non-infectious type? I mean, contaminated or non-contaminated type?
Contaminated.
Contaminated. Okay, any other one?
In pancreatitis, I think it would be exudative.
Yeah.
In systemic inflammation.
I'm asking about the exudate fluid. Normally, when you have an exudate fluid in the lungs, in the pleura, would it be contaminated type or would it be non-contaminated type? What is meant by the contamination?
Sterile, not
Bacteria
infected.
or
Yeah, it will
microorganisms.
always be sterile. It will always be sterile, right? It don't have any bacteria normally. So non-contaminated type is a normal type. Okay. So whenever you have a pneumonia, because of the inflammation, normally you have the leakage of this fluid, right?
Yes.
So it will so it is initially at a very initial times, it will always be a non-contaminated or a sterile type of exudative fluid or a parapneumonic effusion, you can say. Okay. Now, what happens is when the bacteria, okay, they spread and they even involve the pleural cavity, the pleural membranes, then you can have an infection of the pleura also, right?
Yes.
So these bacteria can even infect this exudate, and now this exudate is known as the empyema. Okay, so initially you have the exudate, you have the parapneumonic effusion, which is sterile type, non-contaminated. But when the bacterial infection spreads and involves the pleura also, it will infect this fluid, and now this is known as the empyema.
Okay.
Okay. Now see, what is the difference between an empyema and the normal exudate? In the normal exudate, you won't find any kind of a smell, right?
Right.
Because now second time the empyema is infected with the bacteria. When you draw this fluid, it will be very much purulent, right? Because it is
Right.
kind of infectious, right?
Yes.
So now, other important thing, when the bacteria is lodging to this area, this pleura, ultimately the fibrosis of this pleural space will happen. Okay, and when the fibrosis will happen initially, see, initially when you have this normal exudate or a normal effusion, it is mobile type, right?
Yes.
But when you got the fibrosis in the pleura, in the space, you will get the formation of fluid pockets. Okay, and in these pockets, you have this exudate or the empyema or this pus, right?
Right.
So if you perform a normal thoracentesis, this won't help you. Because of a diffuse fibrosis, you will not be able to extract the fluid as much as you can do normally, right?
Right.
So now the other things will be needed, and these are the fibrinolytics and the DNases. They will destroy all these fibroceptors, and as a result, it will become easier to withdraw this fluid now. Okay.
Okay. Yes.
So step one can ask you the step. If you encounter a patient who's having a fluid-filled pockets in the pleura, fibrosis in the pleura, so what could you do to extract the fluid? So it will be the fibrinolytics and the DNases. This will help in the drainage of the empyema. Okay.
Yeah.
Let me see if I'm not missing anything. Just give me a second. Yeah. So one more thing I forgot to tell you, yes. See, I told you previously, in case if you got any damage, in case if you got a ascites, then this ascites fluid can even leak into the pleura, right? By crossing the diaphragm.
Right.
Remember? So in case of ascites, you can also have the transudated type or exudative fluid.
Transudative.
Exudative.
Why exudate type?
I think it's called a mixed syndrome where we have pleural effusion and ascites. So I thought it's exudative.
Just tell me whether this ascites is a transudate or exudate.
Transudate.
So if I'm
Transudate.
having, if the same fluid is entering in my pleura, will it be transudate or exudate?
Transudate. Transudate.
Transudate, right? Transudate.
Yeah.
If I'm having this exudate fluid in my ascites, then I can have this exudate type of effusion, right? So it depends upon what kind of a fluid you're having in your abdomen, right?
Yeah.
But normally you have the transudate type, so it will be the transudate. If it become infectious, or if the inflammation is also there, then it can become the exudate again. Exudate, right?
Okay.
Yes.
Can you explain how a site
Let
is
me, yeah.
how ascites fluid can leak into pleural cavity?
Because a diaphragm has some openings. It is not a fully membranous, the muscular structure, it has some openings in it also. And by crossing these openings, the fluid can enter into the pleuras.
Those three major openings, right?
Not the three major openings, no, not them, but other smaller openings are also there, like a fenestra in the endothelium. Okay,
Yes.
many small openings are there in the the diaphragm that can be easily crossed by the fluid. Okay,
But peritoneal cavity is closed now.
peritoneal cavity is closed, but not every organ is intraperitoneal, right?
Okay.
Some organs are retroperitoneal, some organs are intraperitoneal, right?
But fluid in ascites is within peritoneal cavity, right?
Yeah, it can easily cross it again also. See, not all these, see, but whatever membrane you have in your body, it is not a fully, fully insulated with the water, right? The water can still cross the membranes, except
Yeah.
if it has some specific kind of modifications. Okay, like in case of a tubules. Other than that, a normal membrane, it could be easily crossed by the water,
Okay.
right? So by just crossing simply water, if the water is crossing these membranes, it can simply enter into the lungs also. Not the lungs, I mean the pleura also, right?
Okay. Right. Thank you.
Let me open this file again. Yeah. So we have discussed that in a normal patient, the intercostal vessels are the majority part, okay, which forms this fluid, okay, while minority is formed by these bronchial vessels and the pleural vessels, okay. Whenever you have some kind of a heart failure, in this case, these bronchial vessels and these pulmonary vessels will become the major contributor of this pleural fluid, right?
Right.
Now, these pleural effusions can also be known as the paranemonic effusions. Okay, you have normally the extudated type of this effusion whenever you got any inflammation. Okay, now this extudate is always without any contamination by the bacteria, so you can call it a uncomplicated type of paranemonic effusion or a sterile type of paranemonic effusion. But as this bacterial infection spreads, okay, these bacteria can even translocate from alveolar space to the pleural space, and as a result, they will contaminate this effusion, and now this effusion is known as the complicated paranemonic effusion, or you can call it a empyema. Okay, finally, fibrotic organizations can happen in our this space, and ultimately it will form the pockets which contain this purulent pus or this extudate, contaminated extudate. Okay, so treatment includes the antibiotics, drainage, fibrinolytics can be given, so they will dissolve all these fibroceptors, and as a result, you can easily withdraw the fluid, right?
Yeah.
Okay, now, any doubt on this effusion part?
I have one doubt.
Yeah.
Is there any difference between pleural effusion and hydrothorax?
Pleural effusion and hydrothorax.
Yeah.
See, a hydrothorax could be outside the pleural also, right? So it can happen anywhere in your thorax. That means that's why the term hydrothorax.
Okay. Okay. Yeah. Thank you.
Yeah. So, okay, so that was about it. And yeah, this is the pleural effusions in the malignancy. You can have because of a metastasis, they can cause, lymphatics blockage also. Okay, and that can happen, and that can lead to the inhibition of this absorption of the fluid. Okay, and similarly in case of lymphatic this drainage, this can also get damaged by these cells, and if they got damaged by these cells, then you will have a lymphatic type of extravasation. Remember?
Right.
So that was happening. Just give me a second. Yeah. Yeah, and one more thing about this hydrothorax that you were asking. Whenever a normal fluid is entered into the lungs, it is a hydrothorax. Similarly, if you remember, I told you in previously, in case of mesothelioma, you will be having a hemorrhagic type of this effusion. Remember?
Yeah.
So this condition known as a hemothorax, for example. Okay, so any kind of a fluid when enters in your thorax, because your thorax is lined by the pleura, right? Itself.
Right.
All this pleura, medicinal pleura, and many other pleuras are there. Remember that the cervical pleura, the medicinal pleura, the diaphragmatic pleura. Remember, all these pleuras are there, which are covering every organ. Okay, so thorax means it can happen in any of these pleuras, right? If the fluid
Okay.
is filling, that will be called this hydrothorax. If the blood is filling there, it will call as a hemothorax. If a pus is there, it can cause a empyema also, right? If a chyle is there, you can call it a chylothorax. If a urine is there, you will call it a ureothorax, maybe, right? Something like that.
Okay.
Okay.
Thank you. Have you encountered any question or any term related to hydrothorax in U world or anywhere?
No. Just a hemothorax that visible in case of mesothelioma only, nothing other. Okay.
Okay. Thank you.
Any more doubt on the pleural effusions?
No, thank you.
So basically, effusion is a type of hydrothorax, you can say. Okay.
Yeah, right.
Okay. After the fluids, you have air. Okay, and you call it a pneumothorax. Okay. Now, in this case, you will be having air in your pleural space, and that can happen whenever you have a damage into the parietal pleura or in the visceral pleura, right?
Right.
If the damage happened into the parietal pleura, it can lead to a leakage of this air directly from the outside environment. If a damage happened into the visceral pleura, it can leakage of the air, so this can leak the air from alveoli into the pleural space, right? Again, it will cause a pneumothorax. So whenever you have a pneumothorax, because one side of a lung is now filled with the air, it will getting so this lung will be getting compressed by this to this air, right?
Yes.
Now, other important thing, remember, I told you because you have this negative pressure surrounding the lungs, that is keeping the lungs totally open, right?
Yes.
So if this negative pressure on my pleuras are lost, then my alveoli and all the things will be collapsed again.
Right.
So that will lead to the collapse of my alveoli and on the lungs, as you can see on this side. Okay, because of increase in this pressure, loss of negative pressure, all of my alveoli will get collapsed. What you will get is a dyspnea, uneven chest expansion, because the part where this air is present, it cannot be expanded properly. So uneven chest expansion will present. Chest pain will be there. Okay, because the air is not present. You will call it a hyperresonance. On the percussion, you will get firmitis. What about the firmitis? Increase or decrease?
Decreased.
Decrease, because you have a loss of vibration because of loss of this movement of the lungs. Okay, you will have a diminished breath sounds, and all of these things happen on the unilateral side. That means on the affected side. Now, one more thing you have to remember about is the diaphragmatic excursion. Stephen can also ask you about this. With inspiration and expiration, how much distance your diaphragm move in between them, you will call it a diaphragmatic excursion. In case of pneumothorax, because your lungs are not, not moving properly. Okay, so what you will have is a loss of diaphragmatic excursion. Remember, right?
Okay.
Okay, so this again, you will have a loss of diaphragmatic excursion in case of pneumothorax. Remember this condition also. Okay. Now, I told you because of this filling of, this pleura with the air, you will have a loss of lung volume, right? Lungs are not expanding. So if the lungs are not expanding, what will happen to my lungs compliance? Increase or decrease?
Decreased.
Decrease. The lung compliance will also be decrease in case of pneumothorax. Remember this condition also. Okay. And in case of pneumothorax, because your pleuras are now in direct contact with the atmosphere, so the pressure inside the pleura, that is the intrapleural pressure, will become equal to the atmospheric pressure. Okay. Loss of negative pressure will lead to the the collapse of all this air. You cannot have the expansion of the lung properly now. Okay. So the volume of the lung will be decreased. Okay.
Yes.
Now, what will happen to my thorax? What about it? Increase volume or decrease volume?
Increased.
Increase volume.
Why increase?
Lose.
Because loss of negative pressure, so chest wall will expand while the lungs
Yeah.
will be collapsed.
Yeah, exactly. I told you the elasticity of lung is collapsing and the elasticity of the chest wall is expanding type, right? And it is a negative pressure between these two things that is keeping, these two layers, very intact with each other, right?
Right.
If this negative pressure is now lost, your chest wall can now easily be, go towards the outside from the expansion, for the elasticity, right? So the expansion of a unilateral chest will happen. Okay. And this will increase the hemithorax volume. Very important. Okay.
Yes.
Important thing this one also. Now let's discuss all the causes. What about the findings? What you will see?
Sorry, what do you mean by hemithorax volume? What do you mean by that?
Hemithorax means unilateral thorax, because
No,
one side thorax is normal, right?
Hemithorax
Yeah.
volume. What is that? Is it the circulation
Chest,
or the
chest,
air volume?
chest. Just a volume, the total volume of a chest.
So how it will increase?
Because you're having an expansion of the chest now.
Okay.
Normally you have a normal chest, and let us say it has 100 ml, 100 liter of volume inside it. If this chest is now expanding, I have more chest or more area now, more space now. Can I accumulate more fluid in it?
More
So
fluid?
more volume, right? Volume could be of air, could be of fluid. Okay.
Okay.
It's just the volume. Volume is basically the height, width, and this the height, width, and this what do you call it? Depth, right?
Okay. Okay.
So length, width, and height multiply, all this volume. So that was the volume, not a volume of fluid or anything else.
Okay.
It's just the size or space inside your pleura is now, the size or space in your thorax is now increasing. Okay. Yeah. So where were we? Yeah, the findings you will see. So encounter a patient, you're suspecting the patient could be having a pneumothorax. You have to perform the X-ray now. So what are the X-ray findings you will see? If anyone knows.
Well, the side affected will be becoming more black, and the central area will be becoming more white because of collapsed lungs.
Okay.
A boundary
Yeah.
of
And deviation.
Yeah, a boundary, a line will be seen,
Okay.
a horizontal or vertical line. Okay.
So
Yeah. Shifting of mediastinum.
Shifting of mediastinum would be there, yes. Tracheal deviation would be there.
hyperinflation and flattening in the diaphragm will be seen.
Flattening of diaphragm. It won't see. I don't think so. It will see. Hyperinflation will not also be seen again.
Okay.
See,
Asymmetrical.
because the complete lung is now getting collapsed. You need some part of lung intact, right, for the hyperinflation.
Okay.
Right. So let's
Yes.
discuss the X-ray findings properly. Let me open an X-ray for you. Now look at this X-ray, and can anyone tell me which side of the lung has been this collapsed, or
Left.
which side has a pneumothorax?
Left side.
Left.
Left side.
Left
This
side.
side,
Left.
right?
Yeah.
This side. Okay, now see, let's see what's happening. On this side, looking at this side, you can see that all these lung markings are present. See, these are the blood vessels,
Yeah.
right? And these spaces, right? On this
Yeah.
sides, can you appreciate any of the lung marking?
No.
I mean, you can see the ribs
No.
easily, no doubt, but you cannot see any blood vessel or any other findings that is in a normal lung, right?
Yeah.
Can you appreciate this demarcating line?
Yeah.
Now, this is the collapsed lung. Okay, this is a collapsed lung. And after this line, it could be a horizontal line, it could be a vertical line, depending upon which side has been collapsed. Okay, so after this collapsed line, after this demarcating line, you cannot appreciate anything inside this lung, right? Because the lung is not there, so no finding at all. So this line is known as the pneumothorax line. This will be seen whenever you have a patient with a pneumothorax.
Yes.
Okay, so that again a very important thing you must look for. Okay, and
How
yeah,
would we know that this is a collapsed lung or something else?
so your voice is breaking actually. Repeat it again, please.
How would we know that this is collapsed
Yeah, this
lung
collapsed is
that
lung.
you have just shown? Yeah, you said that this is collapsed lung, right?
So you're asking how can you be sure that this is lung and not any other tissue, right? Is that what you're asking?
Yeah, exactly. What I was asking.
I think either I have an internet connectivity issue or maybe you have a connectivity issue. I'm not able to hear you properly actually. Yeah, please type. Your voice is breaking too much actually. Are you typing? Okay, so how would you know it's a collapsed lung, not the lung, not a other structure? Is that your question? What other structure you have here beside lung? In a normal X-ray, what other structure you have beside lung? Yeah. Lymph nodes. You have lymph nodes here or here?
Intestinal lymph nodes,
These are here, right?
heart border, heart shadow.
Yeah, these are here, not here. Remember, basal and higher lymph nodes are present and more central part, not in the periphery. As you can see, this is more kind of a medial type, right? Yeah, you have heart here, right? And heart doesn't look like that. See? And besides it, you can see that after this line, you have no lung marking here. Can you appreciate any marking here?
Lung markings.
No marking side. So beside this line, if no marking is present, that will again make you think that this could be a lung. Because if it is not the lung, there must be marking present for the lungs here, right? Let me open another X-ray for you also, so you can have a better understanding. See this one again. After this line, as you can see here, after this line, you have no lung marking here, right? Yes. While on this lung, see, you have all these blood vessels, as you can see, going everywhere. You have lung marking here, but no lungs, because there's no lungs, so no lung marking again, right?
Yeah, right.
See this one also. As you can see, this is a line. And after this line, again, no lung marking. So this will help you. If this line is present and after this line, you are not appreciating anything apart from the lips and a complete black is there. That's how you know that this could be the lung marking, not any other tissue structure, right?
Yeah, right.
And normally you have only heart here. See this one also. And in which part of this lungs you're having this pneumothorax, right or left side?
Right side.
Right side. Everyone agree?
Right side.
Can you? Yeah, everyone agree with that?
Yes.
You can see this line here, right? This is a line of pneumothorax. See, inside this line, you have all these lung markings. But after that, see, everything is kind of a black and just the ribs are present. No lung markings are there, right? So presence of this marking will help you ultimately. Okay.
Okay, thank you.
I think these are all the important X-rays. Other than that, when you perform the CT of a patient, you can even see the fluid, the air is here, right? Now, similar thing will be seen in the effusion also.
But on the lower side.
But on the lower side, and apart from that, it is kind of a black and and this effusion has, because it is opacified, you have some kind of a whitish appearance of that, right?
Right.
Some grayish or whitish appearance, and the air has a complete black appearance here also, right? So
Yes.
this will again tell you that is a pneumothorax case, not a effusion case. So these are the findings you will see in a pneumothorax. Let's discuss what kind of what types of pneumothorax you can have. You can have a primary spontaneous, secondary spontaneous, traumatic, and tension. So spontaneous, that happens spontaneously, of course, as the name suggests. It could be a primary type that can happen because of a rupture of a apical subpleural blab or cyst. If you're having a subpleural bulla or a blab, it can sometimes got ruptured. And if it got ruptured, you can end up having a pneumothorax. Okay. Now, as you go up, the pressure is decreasing, right?
What pressure?
Atmospheric pressure.
Okay.
Right? So a tall individual, their lungs at a higher place, so they will be in a low pressure than a short individual.
Right.
Their their apex specifically is at a very lower this low pressure area as compared to a normal individual.
Yeah.
So these patients is are having a very high chance of developing these bullas or these blabs because of a low pressure environment. Okay, so this condition is most frequently seen in the patients who are very tall, thin, and young. Okay, and they have a very minimal history of smoking. Okay, even a minimum smoking history, apart from having a this tall, thin, and young. Okay, this will promote developing a apical blab or a this subpleural blab, and as a result, whenever this blood got ruptured, patient will got develop a spontaneous pneumothorax. So it will be a patient who's having a height for approximately say 6 feet or 6 feet 4 inch. Okay, and he was just resting at the home, and suddenly he developed this dyspnea, shortness of breath, uneven chest expansion, chest pain, and all these things. You can think about the spontaneous pneumothorax. Okay, no trauma history will be there in these patients, right?
Yes.
Now, other thing is a secondary spontaneous pneumothorax, which means it must be seen a diseased lung. In this patient, lung is totally normal, not diseased. It just he got a rupture of this flap and now he's having a pneumothorax. In case of this secondary spontaneous, they won't have any disease. Okay, but they can, in case of secondary type, you will be having a diseased lungs. It could be due to emphysema. I told you bullas can be formed in emphysema, right?
Right.
So this bulla can get ruptured and you will get a pneumothorax. Infections can do that. Aortical injuries can also happen sometimes. Okay, sorry, the aortic one also traumatic type. Barotrauma can happen. If you give a patient PEEP therapy and if you give too much of the pressure, then then this high pressure can even rupture alveoli, right?
Right.
Alveoli will get ruptured, the pleura will get ruptured, and ultimately will end up having a secondary spontaneous pneumothorax. So COPD patients can be there. This malignancy patients could be there. Okay, a patient could be on the PEEP therapy. He's got the rupture because of a barotrauma, and now he's having a secondary spontaneous pneumothorax. Third one are the traumatic type that can happen because of a rib fracture, It could happen because of a gunshot, that is a penetrating trauma. It can happen during a placement of a center line, that means this iatrogenic injuries. It can happen while performing a lung biopsy. Okay, by performing that, you can suddenly damage this condition. Barotrauma can also happen. Okay, so all these traumatic causes can cause a traumatic pneumothorax, right?
Right.
Finally, after all these causes, okay, if you got a primary spontaneous, secondary spontaneous, or a traumatic pneumothorax, if a valve is formed in any of them, then with each inspiration, you will have a more air in the lungs, in the pleura, but this air cannot get out, right?
Yes.
If a one-way valve is formed, so it will allow the air to go inside the pleura, but it won't allow the air to go outside the pleura, right?
Right.
So with each inspiration, you will have more air inside the pleura, and this would cause a tension pneumothorax. When the air can enter the pleuras, but they cannot exit. This will cause, with each inspiration, you will have more air, more pressure. Okay, tracheal deviation ultimately can happen. See, in this patient, you are seeing the tracheal deviation. That means this patient is having a tension type pneumothorax, right? Not a normal type. You won't see a tracheal deviation in a normal pneumothorax. Only in the tension pathology you can have it. Okay.
Yes.
Now, because of increase in this intrathoracic pressure, patient can also have a displacement of the mediastinum. If the displacement of the mediastinum will happen, it will compress the inferior vena cava. You will have a kinking of this inferior vena cava, and as a result, the venous disrhythm will be decreased, and patient will end up having a obstructive shock.
Yeah.
Right. So this again thing, you will have a loss of cardiac output from the right side of the heart. Obstructive shock will develop in these patients. So you will encounter a patient who, just an hour or 2 hours ago, he developed this uneven chest expansion, chest pain, dyspnea, shortness of breath, and all these things. And now he's also developing the shock. You will immediately know that this patient is having a tension pneumothorax. Apart from that, one more finding that you must remember for this pneumothorax is the subcutaneous crepitus. I told you, whenever you have a air within your skin, you can have a subcutaneous crepitus, right? On the auscultation.
Yes.
So again, you will see the whenever you see the subcutaneous crepitus in the thoracic region, you can think about the pneumothorax. Okay.
Yes.
So these are all the findings and all the presentations you will see in a patient having a pneumothorax. Any doubt, please ask.
No, thank you.
Okay, let's take a short break then.
Okay.
Okay. We'll continue then with the pneumonia. Okay, so let's discuss the cardiogenic pulmonary edema. See, when you have a heart failure, okay, then due to this heart failure, you can have a buildup of all this fluid in the lungs, right? Yes. Am I audible?
Yes.
Okay, so because of this heart failure, you can have a buildup of all this fluid in the heart. Is that okay?
Yeah.
Now, this building up of fluid in the heart could be acute or could be chronic. If I have a sudden onset of heart failure, for example, I got a patient who just have an MI, and I told you whenever you have an MI, you can have a rupture of the valve, you can have and you can have a rupture of this valve and other things also, and that can lead to acute heart failure suddenly, right?
Right.
So you can have a heart failure because of two things. One is the heart failure, which is acute, and second is a chronic heart failure. In case of acute heart failure, you have an acute building up of fluid in the lungs, right?
Yes.
So what is a different? How can you differentiate whether the patient is having all these changes due to a chronic heart condition or due to an acute heart condition? So it would be the engorgement of the veins. Whenever you have a sudden heart failure, sudden loss of cardiac output, okay, sudden heart failure, in that case, all of that fluid will start building up in the veins. And now veins are not draining the blood anymore. So what you will see is the engorgement of the veins. Okay.
Yes.
And apart from that, you will have the alveoli, which are filled with some kind of a fluid, which is of course attached to it. Okay, you have and you will also have a hyaline membranes in the alveoli. So these are all the findings you will see whenever you have a patient with acute heart failure, engorgement of the veins is very important. Okay.
Yes.
Now, when you have a chronic heart failure, then due to a chronic blood loss, all these RBCs will be phagocytosing by the macrophages, and they will be releasing all these irons. So what you will find is the hemocydin-laden macrophages in case of a chronic heart failure. Okay.
Right.
So step one will give you a patient who is having a heart failure. They can give you a patient having a chronic heart failure. They can give you a patient having an acute heart failure, and they will ask you what findings you will see in the lungs. They will give you both the options, engorgement of the veins as well as the hemocydin-laden macrophages, or you can say the heart failure cells. And please note, heart failure cells can only be there if there is a chronic heart failure. In the acute causes, you won't have any heart failure cells, but you will find the engorgement of the veins. Okay.
Yes.
So remember this also. And again, because of all this fluid buildup in the heart, in the lungs, you will have a loss of compliance. Okay. So any doubt in this part?
No, thank you.
Okay, now you have the pneumonia. Causes of pneumonia, you are very well aware of them. Okay, different type of pneumonias are there. One is a lobar pneumonia, second is a bronchopneumonia, third is the interstitial pneumonia, and fourth is a cryptogenic organizing pneumonia. Remember?
Yeah.
BOOP, right? We have discussed
Yes.
that already. So let's discuss a lobar pneumonia. Whenever you have a lobar pneumonia, a complete lobe of one lung or maybe multiple lobes could be affected. Okay. The major agents are the Streptococcus pneumoniae most commonly. Second one is the Legionella, and third most common is the second most common is the Klebsiella, and the third most common is the Legionella. You guys already know the feature of a patient having a Legionella infection.
Low sodium, confusion, diarrhea.
Low sodium levels will be there, diarrhea will be there, a old age patient will be there, right? Having a history of some kind of a hotel or maybe a hospital outbreak would be there, right?
Right.
And the patient could be having a history of smoking also, a smoking patient, old age patient having a diarrhea and now having a pneumonia. This is what you will see in the Legionella, right?
Yes, sir.
Yes.
Very high fever.
Yeah, very high fever would be there, a low sodium will be there, and you have to detect the antigen in the urine, right?
Right.
That thing also. So that was about Legionella. So you can have a you can have a consolidation in the lobe or multiple lobes also, or even an entire lung could be affected. Okay. Second type is a bronchopneumonia, which affects a small portion of lung, just like you see in the fibrosis. Yeah. Is there any doubt?
No, continue.
Yeah. He's having a novel. Okay. Now see, second type is a bronchopneumonia, in which you have a small involvement but a diffuse involvement of the lung. Smaller, these patchy areas of the consolidation will be present throughout the lung. Just like you see in case of interstitial lung disease, you have a reticular opacities right throughout the lungs, bilaterally. Yes. Same thing, same X-ray finding will be seen in the bronchopneumonia. Bilateral reticular opacities will be found throughout the lungs. Okay, that's how patient is having a bronchopneumonia. It could be caused by the Staphylococcus pneumoniae. It could be caused by the Staphylococcus aureus. Remember the post-influenza pneumonia?
Yeah.
Aureus can cause it. Haemophilus influenza and Klebsiella, they all can cause it. So more than one lobe is involved. Bilateral involvement is more common. Multiple areas will be involved. A patchy distribution is there. Third type is the interstitial pneumonia, which is also known as the atypical type of pneumonia. And you guys already know all these bacteria which can cause atypical pneumonia. Remember the mycoplasma, walking pneumonia?
Yes.
You will have a bilateral lung involvement, and lung involvement, when you look on the X-ray findings, the X-ray will be very much worse than the patient symptoms, right?
Right.
Chlamydophila can again cause it. Chlamydia again can cause it, right? Legionella can cause it. Viruses, all the viruses, whenever a viral infection occurs and that is causing a pneumonia, it will always be an interstitial type of pneumonia. Okay.
Yes.
So interstitial areas will be there, alveoli involvement will be there, and chest X-ray again will show bilateral opacities. Okay, just like in case of bronchopneumonia will be there, but a dry cough is there. That is an important thing. In case of interstitial pneumonia, there will be a dry cough. While in case of lobar and bronchopneumonia, most often you will find out that the productive cough. the cuff-wedge sputum. Okay.
Right.
Now, because some amount of bleeding is also there in case of pneumonia, you can have a very rusty sputum or a brown colored sputum. Okay. That is a sputum with the iron and you can say the hemocentrin in it, right?
Yes.
So you encounter a patient having a pulmonary edema. Apart from pulmonary edema, patient is also having a fever. Then you can think about the pneumonia. If the patient is just having the edema, because same findings you can even see in the heart failure also, right?
Yes.
The bilateral patchy involvement in the lungs, you can even find it in the heart failure. But presence of this fever will make you think about the pneumonia, not the heart failure. And again, other conditions of the heart failure will also be there in the patient, like old age and other mechanical problems with the heart would be there. So you see edema with the fever, think about the pneumonia. Okay. Patient will be having a sputum, a productive cough will be there. Okay. While in case of heart failure, dry cough will be there. And the cough could be rusty, very rusty. Okay. And that's because of a iron present. Okay. It could be a green sputum also. And if it is an infection caused by Pseudomonas, right? Remember the blue-green? All these pigments, blue-green pigments, the pyosin and pyovertin of the Pseudomonas aeruginosa, right? So if it is caused by the Pseudomonas aeruginosa, it would be the blue-green kind of this sputum, right? So cryptogenic organism pneumonia, we have discussed that already. Now, how would you know if the patient is having a lobar pneumonia? How would you see? How would you find if the patient is having which this involvement of which lobe? You have to find it also, right?
X-ray.
X-ray findings.
X-ray. You will perform X-ray. How would you look at the X-ray? Because step one will give you X-ray of a patient and who is having this pneumonia, and they will ask you, what side of this lung is involved, and if you find the lung involvement, then what lobe of the lung is involved. They will ask you. Okay, so let's discuss how would you find which lobe is involved in the lung. So there's an X-ray of a patient. Can anyone tell me which side of lung is it? Left or right lung? Is a lateral view of X-ray. Left. Okay. And anyone other? Anyone else?
I think it's the right side.
Right middle.
How would you know it is right?
Because it's the middle lobe which is involved, and the only the right lung is having 3 lobes.
How you can say it's a middle lobe?
Because the middle part is getting involved of the lung. The upper and lower part are black.
I can have the involvement of middle part in my left lobe also. Sorry, this left lung also.
Maybe
If
because
this portion
there's
of my left.
two fissures, the horizontal and the oblique fissure are.
Yeah, the fissures. The fissures. I told you on right side you have 2 fissures, horizontal and oblique, right?
Yes.
And on left side you only have 1 fissure. So if you see this marking on this patient, he's having this horizontal fissure and he's having this oblique fissure. And this is the apical lobe, this is the middle lobe, and this is the lower lobe of the right lung. If it is just a left lobe, this left lung, sorry, then this patient would have only 1 fissure. Okay, not the 2 fissures. Okay.
Yes.
Are we clear this point?
Yeah.
Or someone has any doubt? Okay, let me show you now the complete picture. Give me a second. Now forget this part. Okay, just forget this part. Can anyone, by just looking on this part, okay, this X-ray, can anyone tell me whether it is an involvement of lower lobe or upper lobe or middle lobe?
Middle one.
It is either the middle or the lower.
Okay, how could you say it is either the middle or lower, as it is clearly seen that it is the middle part involved? Why you are saying that?
Because the right lung, it is in such a position that the middle and the lower lobe are. The middle lobe is more on the posterior side and the lower lobe is more on the anterior side. And
You're
they
saying
both
opposite.
occupy the,
Feature is
and they
not
Lower
both
lobe is more on the posterior and middle lobe is more on the this anterior side. See. So, see.
Also,
Appreciating this picture, as you can see, the upper and the middle lobe of this right lung are totally covering the entire surface frontal part, right?
yeah,
See, and this lower lobe is kind of very much posterior, so you cannot see the lower lobe in this X-ray, right?
right.
So even if you have a consolidation in this part, it could be either affecting my upper lobe or it could be affecting my lower lobe.
Yes.
While above this horizontal fissure here, you have this apical lobe. That is for clear, right? Whenever you have this lobe involvement, 100% chances that this patient is having a right upper lobe involvement. But if the involvement is there, you have to perform a lateral X-ray also.
Right.
Okay. And only on this lateral X-ray, you can find whether the patient is having a apical, middle or lower lobe involvement. And that's again by looking at the
Fissures.
these fissures, right? Now, similarly, let me show you one more X-ray, which is for the left side. Yeah. Now you have this a normal X-ray of a patient. Okay. Now see, again on the right side, you have this horizontal fissure. Above that, you are having a apical lobe. Below that, you have both the lobes. But this middle lobe is covering this posterior lobe completely, or the lower lobe completely, right? So the anterior, middle, and the lower lobe is more posteriorly. Okay.
Yes.
Similarly, on this left side, this entire surface that you are seeing is totally the upper lobe of the left lung. Okay, you cannot see the lower lobe of the left lung in the AP this frontal view. Okay.
Okay.
Now, for checking the left lung, you have to perform again the new X-ray, the lateral X-ray. Only in that you can see whether the patient is having this pneumonia in the anterior middle or posterior lobe. The superior middle or inferior lobe. Okay. So again, let's see if this is my left lung, then there would be this kind of a fissure present. Okay. And as you can see, this upper lobe is covering this lower lobe completely, right? In my left lung. See?
Yes.
Appreciating it? All this upper lobe is covering my lower lobe completely. So you cannot see if the patient is having any kind of a pneumonia. You cannot appreciate whether this patient is having a this upper lobe pneumonia or a lower lobe pneumonia. So you have to again perform a lateral view of the X-ray. And on the lateral view, if you find some lesion here or anywhere in this region, that means the patient is having a lower lobe pneumonia. If you find the patient is having more upper lesion, that means it must be the upper lobe pneumonia. Okay.
Yes.
is there any hint can we get from the costophrenic angle?
Sorry.
Is there any hint that we can get from the costophrenic angle?
Is there any hint that we can what?
That we can get it from the costophrenic angle in the anterior posterior view?
Sorry, I don't understand you actually. What you're trying to say?
If there is an X-ray, just X-ray of the anterior posterior view, okay? Can we get a hint, a clue from the costophrenic angle if it is a middle or the lower lobe?
Can we get okay? You're asking about any hint?
Yes.
See, if the lower lobe is morely involved, then you can have a blunting of this angle also. Okay.
In both the lower and middle, it will be blunted?
Yeah, it will be blunted again. Yes. But again, only if see, most of the times you will see the blunting in case of this diffusion, not in case of pneumonia. Very rarely you can see this blunting of the angle.
Okay, it will not be affected in pneumonia cases.
Yeah, it mostly not affected. It mostly affected only in case of effusion. If you see the blunting of this angle, that high chances are there that this case is a this effusion case, not a pneumonia case.
Okay, so it cannot be helpful here.
Yeah. Now looking at this X-ray, what findings you guys can appreciate? Can anyone tell me what disease this patient might be having?
Sarcoidosis.
Sarcoidosis. Okay. Anyone want to try?
EP diameter is increased, so maybe COPD.
Okay. How you can say the AP diameter is increased? You don't have any inch tape, right?
Yeah.
Hyperlucent lungs.
How can you say the hyperlucent lungs? Can you see any rib findings here?
Markings are decreased.
Markings are, well, this could be due to a defect in the X-ray also.
Is there a subcutaneous emphysema?
How can you say the patient having a subcutaneous emphysema? You have not performed any auscultation.
Okay.
Looking at the X-ray only, how you can say the patient having a COPD? Of course, this patient is having a COPD. I'm telling you that. Now, how can you say the patient having a COPD? And definitive thing that you might be looking for.
Flattening of
the diaphragm. See, this patient is having a horizontal diaphragm, right? Appreciating that?
Yes.
Complete horizontal diaphragm. Normally, you have the diaphragm like that, right?
Dome shape, yes.
So this flattening of diaphragm will tell you that patient is having a emphysema. Okay? Yes. Yeah, that was again a normal view, lateral view. Again, you have to find, looking for the fissures in the X-ray. If you're seeing oblique fissure only, no horizontal fissure, means the left side. If you're seeing both the horizontal fissure and this oblique fissure, that means it is on the right side. Sorry, left side. Sorry, right side. Yeah. I'm getting it. Yes. Sorry about that. Okay. Is that clear for everyone now? Or any doubt is there?
Thank you, doctor.
Clear.
So the oblique and horizontal fissures?
Yeah, for the oblique and horizontal fissures, yes.
I mean, can you show those fissures in this X-ray?
Oh, no, you cannot find these fissures in the X-ray normally. It will only be visible in case of pneumonia cases.
Okay.
When you have the pneumonia, because if you're having a lobar pneumonia, it cannot process the lobe normally. So that time you can appreciate that, but not not like normally you won't see that. Okay. Now let's say what natural history, what findings you will see when you perform the biopsy of a patient at different intervals. The patient has pneumonia on day 0. Within day 2, if you perform the biopsy, what you will find is the X2-8 and bacteria mostly. Okay. You will have a red-purple partial consolidation of the parenchyma. So reddish parenchyma will be there, blood will be there, bacteria will be there, X2-8 will be there, X2-8 will be there, right? And that's again, I told you, as soon as you have this infection, you will only find the bacteria. Now, within these 3 days, the neutrophils will arrive at the location, right?
Yes.
So now if you perform the biopsy after 1 or 2 days, what you will find is the X2-8 again, X2-8 will be there, bacteria will be there. But now because of leakage, because of all these inflammatory mediators, RBCs will be leaking from the blood, neutrophils will be leaking from the blood, right?
Yes.
Then after 4 or 5 days, I told you after 3 days or this 4 days, the neutrophil time will be over and now macrophages will arrive at the location, right?
Yes.
Again, in case of lung, within after 5 days, the macrophages begin replacing the neutrophils. So now in WBCs, you will find many macrophages and a small number of neutrophils. Okay. And presence of macrophages means the infection is kind of over because neutrophils are decreasing. So infection is now over and now healing process might begin. Okay.
Yes.
So you don't see any bacteria now. Bacteria are only up to day 4 when the neutrophils were there and they were killing all these bacteria. Now neutrophils has killed all the bacteria. Macrophages arrived at the location. They check for any bacteria if it's there. If the bacteria are still there, they will recruit more neutrophils. If the infection is over, now they begin the healing process, right? So fibrin will there, WBCs, mostly macrophages will be there, lysed RBCs will be there. Up to this 8th day, after 8+ days, okay, all these macrophages are cleared, have cleared all these RBCs, X2 and everything. Okay, and now again, the regeneration will happen with the type 2 pneumocytes, right?
Right.
So after 3 weeks, approximately, this lung parenchyma will become totally normal again. Okay, it will achieve total normal appearance again back to. So initially red appearance, then red brown, then uniform gray. Okay, and this is known as a gray hepatization. This is known as a red hepatization, and this is the congestion phase. In the congestion phase, you will be having a alveoli filling with the fluid, exudate. In case of red hepatization, RBCs will be there, blood will be there, so appear red. In case of gray, you'll be having some amount of maybe fibrosis will be there, coagulation will be there, macrophages will be there, dead space will be there, dead bacteria will be there. Okay, and in case of resolution, all the macrophages, they will have cleared all this infection and everything, right? And now the healing process will start totally. Okay.
Yes.
Now, symptoms of the pneumonia, patient will present you with symptoms of dyspnea, cough, productive cough will be there in case of lobar pneumonia with rusty sputum, fever and chills will be there. Okay, patient will also be having a pleuritic chest pain. Whenever you have an irritation of the pleura, you will always have a pleuritic chest pain. Whenever the patient inspires, he will have pain with the inspiration, with the expansion of the lungs, and that is called the pleuritic chest pain. Okay.
Yes.
Yes.
So these are all the findings or the symptoms you will see in a patient having a pneumonia. And again, you will perform all this, this percussion test, dullness will be see, breath sounds will see, the bronchogenic breath sounds will be there, right?
Yes.
And what are findings? You will have increased vibrations, right? And X-ray will support your diagnosis. So any doubt on the pneumonia?
What is pulmonary bronchi?
Bronchitis, I told you, whenever you have a mucus plugging in the lungs, you will have a sound known as a bronchitis. Remember 3 sounds I told you: wheezing, rhonchi, and this crackles.
I missed that part, so maybe.
Oh, okay. So you have the crackles because of all this collapse of the alveoli and airways. You will have rhonchitis because of mucus plugging, and you will have wheezing because of narrowing of the airways. Okay.
Okay.
Yes.
Now, other thing, patient can also have a aspirational pneumonia. Whenever patient become unconscious and he aspire the fluid in the in your mouth, maybe the food or could be anything, you will call it a aspirational pneumonia. So for the aspirational pneumonia, having a history of unconsciousness must be there, right?
Yes.
Right.
So you will suspect this kind of a case in case of any patient having an altered mental status, maybe a dementia, maybe due to a drug intoxication. It could happen in a patient who recently had a stroke and loses a consciousness. It could be in a patient having a neurodegenerative disorder. Okay. It could be in a patient having a history of regurgitation, that means the GERD. And if you guys remember about, in this the GI lectures about this Zenker's diverticulum, I told you patient can have a recurrent history of aspirational pneumonias, remember?
Yes.
So Zenker's diverticulum can again lead to this condition. Any mechanical compromise, if happens with the airway, this can again lead to the aspirational pneumonia. For example, if the patient is having a nasogastric tube, if the patient is having this endotracheal in this tube intubation, in that case, patient again can have a aspirational pneumonia. Okay, any this amyotropic lateral sclerosis, remember, patient become too weak to cough. He will end up having recurrent episodes of aspirational pneumonia and finally die because of that, right?
Yes.
Right.
So ALS can happen in that case. If a patient is having a recurrent vomiting or the protective vomitings, in this case also patient can have aspiration of some of the vomiting, and that can again lead to the aspirational pneumonia, right?
Yeah.
Now, when the patient aspire this the fluid in the oral cavity or the food in the oral cavity, what bacteria patient can have in the lungs?
Oral anaerobes.
Oral anaerobes. And does anyone remember any name of the oral anaerobes?
Acinetobacter.
Okay, and
Canella.
Klebsiella could be there, yes. And
Aikenella.
anaerobes,
Essay
Anaerobes mainly I'm asking. Yeah.
group.
What are the main anaerobes of your oral cavity?
Fusobacterium.
Fusobacterium, Bacterstreptococcus, bacteroids. Remember?
Yeah.
So these are main organisms residing in your oral cavity. So you will always find these organisms in the lungs. Okay. When you perform this lavage of the bronchoalveolar lavage and sputum analysis, you can find these bacteria even, right? Now, again, the same concept. If you aspire the fluid on the standing position, it will go to the base. If you aspire the fluid on the supine position, it will go to the superior, or you can say the apex of the posterior lobe or base of the apical lobe, right?
Right.
This thing again, anaerobes mainly present. Okay, on the microscopic finding, what you will see is the foreign body response will be there, giant cells, inflammations. I told you giant cell is a marker of inflammation, right?
Yes.
And what is a marker of granuloma?
Epithelioid cell.
Epithelioid cells. Good. Now, because the anaerobes are there and neutrophils will be there, you can also end up having a lung abscess because of this.
Yes.
And what is a lung abscess, if anyone knows? What is an abscess? Not a lung abscess. What is an abscess?
Collection of pus.
And how this pus is formed?
Walled off
Yes.
collection of
Walled
pus.
off.
Walled off pus. Okay. And what is a pus?
Neutrophils.
Neutrophils. Okay. And what is a
And
neutrophils?
all those dead bacteria and dying bacteria.
Just the bacteria and neutrophils, nothing else.
Necrotic bodies.
Necrotic bodies. Okay. And what type of necrosis will happen in case of abscess?
Liquefactive.
Exactly. So you will have a liquefactive necrosis because of neutrophils. They will releasing all these enzymes, right?
Yes.
So ultimately, this even a normal pneumonia, if it becomes severe, can progress to a lung abscess. Not just this especially pneumonia, even a normal pneumonia can progress to lung abscess. And when this lung abscess happen, a part of the parenchyma become died completely. So patient will end up having a cavity lesion, just like the tuberculosis, right?
Yes.
So this cavity lesion is not just a feature of the tuberculosis, but it can happen in any case whenever you have an abscess in the lungs. Okay. So let's discuss this abscess now. See, with the abscess, you will have a localized collection of a pus within the parenchyma, and this is completely walled off. In this pus, you will be having all this necrotic material, which is the liquefactive necrosis. Okay, bacteria will be there, neutrophils will be there, which are causing all these this inflammation thing, right? It can happen because of a oropharyngeal content aspiration. Okay, and I told you all the conditions where patient can have aspiration. Epilepsy could be there, alcoholism could be there, drug intoxication could be there. Okay, or this ALS could be there, right? Or it can also happen because of a bronchial obstruction that generally happen in case of cancer. If a pneumonia has happened and pneumonia is progressing too much, it can again lead to the abscess. Okay. Mostly you will find the anaerobes in case of this, especially pneumonia. What you will find is the bacteroids, Fusobacterium, Bacterstreptococcus, or even the Staphylococcus aureus could be there sometimes. Okay. So, and most oftenly, I told you whenever you have a lung abscess due to aspiration, it is most oftenly going to the right lung, right?
Yes.
And again, the position of the patient will determine at what side this aspirated fluid will go, upright position or lying down position, right? Step 1 will ask you, what is the reason behind this lung abscess? It is a liquefactive necrosis by the neutrophils, right?
Yes.
And again, because you're having an abscess, you're having an anaerobes there, they will feed on your food, your carbohydrates, and they will release gases. And that will give the sputum a very foul smell. So patient will be having a very foul smelling this sputum. Okay. Now, if sometimes patient can have more anaerobes in the mouth if they have unhygienic conditions, right? So these patients who are having, because mostly they will give you a patient of alcoholism or something like that, who, a patient who cannot take care of himself. So these patients must be most of the times these patients will be having a very poor hygienic environment in the oral cavity. They will be having a very poor dentations. Okay. They will be having a, the gingival services will be there, and the Rops bacteria will be found there mostly. So again, this thing is very important. They will have a very poor dentition or very poor hygienic environment in the this oral cavity. Again, suggest a diagnosis of your lung abscess. Treatment, because not just the anaerobes but aerobes are also there in abscess, right? For example, the Klebsiella, right?
Yes.
So you have to choose a drug which can control both the anaerobes as well as the aerobes. So can you give the patient metronidazole?
Yes.
Yes, it covers
Yes.
anaerobes.
It covers anaerobes, but can it covers aerobes also?
No.
Oh,
No.
it does.
Metronidazole do not cover the mainly anaerobes which you want to target. So you cannot give the metronidazole in case of lung abscess. Okay. The mainstay treatment is giving the patient clindamycin. Okay, because it is a drug that can covers both the anaerobes as well as the aerobes. And because it is always multibacterial, you have to give an agent which can cover both, right?
Right.
So clindamycin is a drug of choice because it can covers both the aerobes as well as the anaerobes. On the bronchoalveolar lavage, you will find the neutrophils there, neutrophilia. Okay, WBC count again in your blood will be increased. You'll be again having fever, shortness of breath, pleuritic chest pain, and all these things will be present. So that was about the lung abscess. Any doubt, please ask.
No, thank you.
Let's discuss the lung cancer.
So one question is
Again,
there, like,
yeah.
whenever there is a lung abscess, does it often like completely get cured with these medications, or
See, when the lung abscess happens, you can just remove, what is gone, now gone. See, what is gone is now gone. You cannot cover that, okay? A cavity lesion will always be present in the patient's lung. You cannot recover that. It's just you have to remove the infection now. You have to drain the pus, okay, in your lungs, okay?
So we need
So complete regeneration won't occur.
so we need intervention and medication together, right?
Yeah, exactly. You need to remove this fluid first. After removing the fluid, you need to give the patient medications to, just cover up all this infection, right? Now, one more thing I told you is a complication. Whenever you have a cavity lesion, one organism will always colonize this. And does anyone remember the name of that organism?
Aspergilloma.
Yeah?
Aspergilloma.
Aspergillus. Yeah, you will always have a colonization of this this cavity with the aspergillus, and it will form a fungus ball there that is known as the aspergilloma. Okay.
Yes.
So patient will be having all this. Again, it would be a patient who has this previous lung cavity because of abscess or because of TB, and now he's having this filling of this cavity now. So you will immediately know that patient must be having a filling with aspergillus, right? Now let's discuss the lung cancer, which is again a leading cause of the death. Majority symptoms are the cough, hemoptysis. Bleeding is very important. Okay, patient will be having a cough. A very long history of cough will be there, more than 2 or 3 months or 6 months even. Okay, and now the patient is having a hemoptysis. Sometimes bronchial obstruction can also happen if this cancer is very much central. Okay, wheezing can also happen because of this obstruction. And when you perform the X-ray, you can find a nodule in the lungs that is like a coin lesion. Okay, don't remember this coin lesion. You will find a nodule in the lung, unilateral. Could be on the right side, could be on the left side. Apart from that, you will also find the lymphadenopathy in the patient, right?
Yes.
So lymphadenopathy with a mass, always think about the tumor. So you encountered a patient having these symptoms. You have performed the X-ray. In the X-ray, you have find this the lesion. Okay, and apart from this lesion, the patient is also having the bilateral lymphadenopathy. You have seen it. Now, other thing, now you have to give, the next step you have to do is to perform the biopsy in the patient, right? To confirm what kind of a cancer is it. Yes?
Yes.
So we will discuss all of these findings one by one now. Before that, you have to know that this lung cancer can go to the liver, can go to the adrenals, can go to the bones, can go to the brain. And mostly when it go to the bones, it can lead to the resorption of the bone, remember?
Yes.
Osteolytic metastasis, right?
Yeah.
Now, when you encounter the patient, you have confirmed the cancer, you have treated the patient. Sometimes patient can also develop these all these complications. For example, if there's a apical tumor, it can lead to superior vena cava syndrome. If it is a Pancoast tumor, can also happen. Okay, which is again a apical tumor. Okay, Horner syndrome can also happen because of that. If it compresses the sympathetic chain. Endocrine symptoms can also be there. If it is a tumor releasing all these hormones, it can lead to the paraneoplastic syndrome also. If the tumor again is in the apical region, it can compress the recurrent nerve, right?
Yes.
And can anyone tell me among right or left recurrent nerve, which nerve will be most commonly compressed, right or left?
Left.
Why left?
Left enters the thorax.
And not right?
No, right simply enters the neck region and does not enter the thorax.
Are you sure is it left or right that you're saying?
Left enters the thorax because it comes near the arch of aorta.
Winds around the arch of aorta.
And
Okay.
right winds around the subclavian artery.
Okay, yeah.
Right subclavian.
Yeah, good. So you have this arch of aorta. Okay, and this arch of aorta giving a branches. This is the brachiocephalic trunk where you have this the carotids, common carotid, and you have this subclavian, right? So the right-sided one will loop around here, okay, and then just go up like that. While the left one, okay, it will, remember this ligament,
Ligamentum arteriosum.
the ligamentum arteriosum, it will loop near it, right? And after
Yes.
looping it, it will go up, right? So most oftenly, when you have the cancer, it can compress this recurrent nerve, and you can end up having the hoarseness now, right?
Yes.
Yeah, so the question was right one or the left one? Which one will be compressed? Yeah, that was the question. I forgot. Sorry. Yeah. If you're having a apical tumor, left one or right one, which will be
Right.
compressed?
Left one.
Right.
Okay, why not left?
Because left is more near the mediastinum and right one I think is more near the apex.
Exactly. Right one is more near the apex, and that's why this will be compressed more, right? So if you're having this hoarseness, most often chances are there that this could be a tumor of right side. Okay.
Yes.
Anyone have any doubt in this? See, you have this right recurrent nerve and you have this left recurrent nerve. Okay. The right one is loop around on this the subclavian artery and then going upward, while this left one is looping around this arch of aorta and then going upward. Okay. If we have a apical tumor, apex is near the subclavian arteries in both the sides, right?
Yes.
So if you have an apical tumor, it will compress the this nerve which is looping on this arteries, right? Which is more upward, not a downward, right? Because this arch of aorta is near the heart, which is in the center of the lungs, right? This is the lung, and this is the mediastinum, right? So if you have an apical tumor, it has more chances are there that it will compress the nerve which is more upward, right? So the right nerve will be compressed more than the left. So whenever you have a hoarseness because of a tumor, because of this this lung tumor, most chances are there that this tumor is on the right side, not on the left side. Okay.
Okay, I got it.
Yes.
Thank you.
So hoarseness would be there. Effusions can also happen. Okay. And yeah, those tumors who start with the S, squamous cell carcinoma and small cell carcinoma, they are always associated with the smoking. So now we have encountered the patient having a cancer. We have confirmed that this patient might be having a cancer. We have to perform a biopsy. We have taken the biopsy of the patient. Now looking at the biopsy, if you find the cluster of dark small blue cells on the biopsy, okay, it is kind of very much chaotic, but if you guys can appreciate, these are the small round blue cells, right?
Yes.
So these are the small round blue cells. If you see something like that, that means you're looking for the small cell carcinoma. Okay. this tumor on the X-ray will always appear more in the central location. So near the mediastinum, you will find this cancer. Okay. Now you have performed the biopsy. Other test you can do is to check for the neural markers. Okay. So this tumor will be positive for the chromogenin A, okay, neuron-specific enolase, and the synaptophysin. Other marker includes the neural cell adhesion molecule, which is CD56. So these are the 4 markers which are positive for this cancer, because this cancer is neuroendocrine tumor, right?
Yes.
So because this tumor is neuroendocrine tumor, this will having all these 4 neural markers positive. Okay. And these cells will have a very large nucleus, but a very scanty cytoplasm, just like the lymphocytes. And that's why these small dark blue cells, dark blue because of the nucleus. Okay.
Yes.
Now the other symptoms, other than having this chest pain and all this, the bleeding, cough, other symptoms of the lung, other than the lungs, symptoms could be, sometimes this tumor can release a ACTH. And if this tumor releases ACTH, the patient can have a Cushing syndrome. This tumor can release a ADH, patient can have a SIADH because of that. This tumor can even release the antibodies against the presynaptic calcium channels, and you will end up having a Lambert-Eaton syndrome. Okay. And if you have a Lambert-Eaton syndrome, the paralysis will start in the lower limbs, remember?
Yes.
Lower limbs first, then upper limbs mainly, right? And apart from that, you will also having the autonomic symptoms like dry mouth and other things, right?
Yes.
So these things will be presented as a symptoms of the this Lambert-Eaton syndrome. Okay. Other than patient, the patient can also have antibodies against the cerebellum, Purkinje cells, remember?
Yeah.
So this thing again can also happen. You will get a subacute cerebellar degeneration because of that. And please note, it happens because of an amplification of MYC oncogenes. Remember the CMYC, NMYC, and one more MYC was there. CMYC, NMYC, and one more MYC, if anyone remember.
The one in Hodgkin lymphoma.
Let me check it. NMYC you have, CMYC you have, and LMYC also. Yeah, LMYC, LMYC, NMYC, and CMYC. Okay, CMYC for the Burkitt's lymphoma, NMYC for the neuroblastoma, and LMYC for the small cell lung cancer. Okay.
Yeah.
So you have the LMYC, this oncogenic amplification in case of small cell lung cancer. Okay. So these are majorly, these cancer are mainly originated from the major bronchi. So that's why these are always more central. Okay. Osteoblastic metastasis is a very common characteristic of this small cell lung cancer. Only very few cancers can have this kind of metastasis. Hodgkin's lymphoma can do that. Small cell lung this cancer can do that, and the prostate cancer can do that, and breast cancer also, right? Well, rest of the cancers, they always have a osteoclastic metastasis, right?
Yeah.
So these are all the features associated with a small cell lung cancer. Any doubt, please ask.
No, thank you.
Now comes the non-small cell lung cancers. The first one is the adenocarcinoma. Whenever you see the adeno word, that means it will always be having a glands, right?
Yes.
So this tumor again will be having many glands, and they will all be releasing the mucus. So when you perform the histology, the biopsy of a patient, what you will find are lots and lots of mucus, as you can see, right? Lots of mucus will be seen on the biopsy of the patient. Okay, mucin will be positive on the staining. Okay, now you will also have a subtype of this cancer that grows in between the 2 alveolar walls. You have one alveoli, okay, you have second alveoli. Okay, this tumor can invade in between the wall of these 2 alveoli. Okay, and you will call it a bronchoalveolar subtype. Okay, so this bronchoalveolar subtype will grow along the alveolar septa. Okay, it won't have any invasion in the alveoli. Please remember, it won't have any invasion in the alveoli. It will remain only in the interstitial space between the 2 alveoli. Okay.
Yes.
Now, if you look at this, it will appear as that the wall of these alveoli septa are getting thick, right?
Yes.
So it will appear as a consolidation on the chest X-ray because of thickening of the septas in between the alveoli. That means increase in the interstitial space. If you have, this will appear as a consolidation, or you will have a a kind of a diffuse involvement of the lungs also. The reticular opacities will be seen on the X-ray, right?
Yes.
So this will happen with the bronchoalveolar subtype of this cancer. Okay, so you have performed the biopsy. You have confirmed the patient is having adenocarcinoma. What other step one will ask you? What other symptoms you can have? You can have a hypertrophic osteoarthropathy because of that. And I already told you the reason behind it. The macrophages, remember?
Megakaryocytes.
Oh, yeah, sorry, the megakaryocytes. Sorry about that. So megakaryocytes will bypass the lung. They will enter into the peripheral tissues. They will go to the fingertips, causing the clubbing there, right?
Yes.
So hypertrophic osteoarthropathy can happen because of that condition. Stephen will ask you, these mutations are very important for this adenocarcinoma specifically. Stephen will ask you what mutation can lead to this cancer. So these are the KRAS mutation, EGFR mutation, and the ALK mutation. Remember the function of this ALK? What does this ALK do?
Tyrosine kinase.
Tyrosine kinase what? Enzyme?
Receptor, I think.
Receptor. It is a receptor for tyrosine kinase, okay? So ALK can do, and can anyone remember other cancers which are associated with the RAS mutation?
Colorectal.
Colon cancer.
Yeah, AK40, sorry, AK53, right? You have to remember this mnemonic. AK53 for the colon, the colon cancers, right? So colon 1, lung cancer 2nd, pancreatic cancer will be there, right?
Yeah.
And what about the papillary thyroid carcinoma?
BRAF mutation.
Yeah, it was RAF, not the RAS. Okay, so don't confuse between two. RAS is for the pancreatic, lung, and colon. RAF is for the papillary. Okay. Yeah. So let's get back to again this adenocarcinoma. So KRAS mutation will be there, EGFR mutation will be there, ALK mutation will be there. So these three mutations can lead to the adenocarcinoma. Patient will be having a reduction of his sputum. Okay, it could be a watery sputum. It could be very much whitish in appearance. Metastasis to the pleura can also happen. That can lead to the pleural effusion again. This patient can have a pleural effusion. This patient, because this tumor is more peripheral, so when you perform the X-ray of the patient, you will find a peripheral tumor instead of a central. You will find a lesion on the periphery, right?
Yes.
This thing again will help you determining what kind of a cancer it could be, because most of the cancers are always central. Okay, only very 1 or 2 cancers are only the peripheral, and one of them is the adenocarcinoma. So it is always the periphery. Okay.
Yes.
So bronchial subtype can appear as a pneumonia because it has a very hazy appearances, because multiple alveoli could be affected. Septas between the alveoli could get thick because of the this cancer infiltration. So it will appear as a pneumonia sometimes. Okay. Note this thing also. Any doubt on adenocarcinoma?
No, thank you.
And please note, if you encounter a patient having a carcinoma and you are not sure with after looking at the CV, what kind of a cancer it could be, so always take the adenocarcinoma in that case, because it is a most common type of cancer. Almost more than 50% of cases of of these lung cancers are of this adenocarcinoma. And specifically, if the patient do not have any history of smoking, you can be very much sure that this patient might be having the adenocarcinoma. Okay.
Okay.
Other thing is the squamous cell carcinoma. Okay, and it is again central, associated with the smoking. And just like any other squamous cell carcinoma, you will be having a creatine pulse, right?
Yes.
And you will also be having a positive markers like the cytokeratin. Okay.
Yes.
Now, other than that, patient will be, and yeah, this cancer will arise from the bronchus, and that's why it is always in the midline, central. The patient, this cancer can release the parathormone related peptide or parathormone like peptide. So this can again cause the hypercalcemia. Okay. Cavity lesion will be seen in the X-ray of the patient. Okay. So that was about this squamous cell carcinoma, and these are the creatine pulse. right? Filled with the keratin. Okay, so now any doubt on this squamous cell carcinoma?
No, thank you.
Other one is the large cell carcinoma. It is again peripheral, and if you find, if you see a patient having some kind of a nodule in the lung on the X-ray with a bilateral lymphadenopathy, and on the biopsy you have find these giant cells, you can think about the large cell carcinoma. It is highly anaplastic tumor, and I told you a feature of anaplastic tumor is it cannot be differentiated, right?
Yeah.
And these cells are totally focusing on the division, not on the growth, not on the function. So they can mimic anything. You can even find the giant cells which are found in the inflammation. Okay, these cells can even become the giant cells, right? So loss of this NC ratio, loss of this polarity, a very high NC ratio, abundant mitotic figures, abnormal type of shape and size of the cells, even giant cells could be there. All this show you a very high grade tumor, or you can say a high anaplastic tumor, right?
Yes.
So because it's anaplastic and differentiated high grade, this tumor has a very poor prognosis. Other one is the bronchial carcinoid tumor. I told you can have a carcinoid tumors in the lungs also, right? Just like any other carcinoid tumor in your GIT, these patients can also have, the wheezing, okay, flushing, diarrhea, right? Because it release large amount of histamine and other things, right?
Yes.
So again, the patient will be having, the wheezing, diarrhea, and flushing, just like any other carcinoid tumor. Large amount of histamine will be released by these tumors again, okay? And because because all the carcinoid tumors are a part of your neuroendocrine tumors, so these tumors will also be positive for the chromogenin A, the neurospecific enolase, synaptophysin, right?
Yes.
Just like any carcinoid tumor, you will find the islands of the tumor cells, which are very, bluish kind of cells having, some pepper-like appearance of the cytoplasm. Remember?
Yeah.
Some granular cytoplasm will be there in the center of the cells, right? So all these things will be seen when you see the carcinoid tumor of the lung, okay? Again, this tumor will be very much central, and mass effects, of course, will be there, like obstruction, maybe, okay? Yes. So when you, when the CV mentioned you a polygonal cells, okay, nest of polygonal cells, and these polygonal cells have a very granular cytoplasm, you can think about the carcinoid tumor, okay?
Yes.
Other than that, patient can also have a hamartoma in the lungs, and just like any other hamartoma, you will have a normal tissue, okay, but a very abnormal kind of architecture, right?
Yes.
When you take the biopsy, you will find the patient is having in this tumor is having a cartilage, having a fat, smooth muscles, okay, all this epithelium, respiratory epithelium will be present, but all of them in a disorganized manner, right?
Yes.
And this must be a very well defined point lesion on the X-ray will be there. So that is a hamartoma. Again, it can happen, okay? So it is a benign tumor, and it is also known as a pulmonary chondroma. So Stefan can ask you, what are the features of a pulmonary hematoma? They must be having a cartilage. He must be having a hyaline cartilage. Must say that hyaline cartilage, smooth muscles, respiratory epithelium, okay, adipose tissue. These are all the findings in the hematoma. Okay. Okay. Yeah. So any doubt with lung cancer?
Can you show the giant cell in?
I have to search. Just give me a second. Let me show you a proper histology. Yeah, these kind of a cells they will be, okay. As you can see, multiple nuclei are present, but they're not like a normal giant cell, right? A normal giant cell will be having a horseshoe shape appearance of these nuclei, right?
Yes.
Yeah.
And exactly same. Look at this cell. This is a complete cell, okay, and you're having multiple nuclei in them, right? Okay, so these kind of a giant cells will be seen on the biopsy of a patient when you perform biopsy of a large cell carcinoma patient, okay?
Right. Thank you.
So that was the biopsy of large cell carcinoma, pleomorphic giant cells. Now any doubt?
No.
Okay. So let's discuss a Pankos tumor, which is a tumor from the superior sulcus. It is also known as a superior sulcus tumor. It arises from the apex of the lungs. And because it is arising from the apex of the lungs, it can compress the structures which are present near your shoulders or axilla, right? Or the necks, right?
Yes.
So this can cause a compression of the recurrent laryngeal nerve, can cause the hoarseness. It can compress the striate ganglion. If you guys remember from the Horner syndrome, it can cause the Horner syndrome. You will have a ptosis, meiosis, anhidrosis. Sometimes be seen, sometimes not be seen. So most oftenly when they give you a CV of a patient, it will mostly this ptosis and the meiosis in a patient. Okay, and looking at only these two symptoms, you will have to find whether the patient is having a Horner syndrome or not. Okay. Similarly, superior vena cava can be compressed, and if the superior vena cava is compressed, it cannot drain the fluid from the upper part of the body, from head and neck, right?
Yes.
So patient will be having a bilateral swelling now, right?
Yes.
So this patient will be having a bilateral swelling of the neck, face, even the arms. Okay, as you can see, blanching lesions will be present because all these vessels are filled with the blood. If you come, if you press it on the skin, then the blood at that area will be gone in the vessels because it compressed now. It compressed now, right?
Yeah.
So when you release it, again, you will have the redness back there, right? So this kind of a blanching lesions will be seen uh, on the examination of a patient, right? Apart from that, patient will also be having a jugular vein distension because they ultimately will be draining blood into the superior vena cava.
Yes.
So that's the other finding you can see in the patient. Other than that, swelling will be there, and engorgement of the veins will be there on the extremities, right? On the shoulders, on the extremities, you will see engorgement of the veins, right?
Yes.
So these are all the findings you will see in a patient having a superior vena cava syndrome. The finding must be bilateral. Okay, and these findings can only be happen in case of Pankos tumor. No, it can happen due to any major cell mass, not just the Pankos tumor. Okay, but if you're having a hoarseness and Horner syndrome, okay, along with this swelling type thing, then you can only suspect the Pankos tumor, not any major cell mass, because any major cell mass can compress the superior vena cava, but only a Pankos tumor can cause, all this Horner syndrome and hoarseness on this superior vena cava simultaneously. Okay.
Yes.
So apart from a superior vena cava syndrome, if any of these are available, if you see in a patient, that means chances are the patient is having a Pankos tumor, not any other mediastinal mass. For example, thymoma can also do that, right? Any kind of a lymphoma can cause the same syndrome, but just the superior vena cava syndrome, not any other finding. Okay.
Yes.
Now, sometimes instead of compressing the superior vena cava, the tumors, these mediastinal masses and other tumors can also compress the brachiocephalic vein only, right?
Yes.
And you have a compression of brachiocephalic vein only, then the symptoms must be unilateral, right? Not a bilateral.
Right.
So a unilateral symptoms if present, think about the brachiocephalic vein, and both the head and neck will be involved, and these are these upper limbs, right? Both head and neck and upper limb will be involved at one side completely, right?
Yes.
Because of clavin vein and these carotids, these jugulars, they combine to form this brachiocephalic vein, right?
Yes.
So when this brachiocephalic vein is compressed, patient will have a unilateral swelling of one side of the body, upper part. If the superior vena cava syndrome is there, then bilateral swelling will be seen. So you have to be very careful by choosing in choosing the option, whether it is a unilateral symptom or whether it is a bilateral symptom. If the unilateral is there, means brachiocephalic, bilateral means Supravena cava. Is that okay?
Yes.
Other than that, patient can also have the compression of brachial plexus. And what part of brachial plexus would be compressed?
Inferior trunks.
Yeah, you will have a compression of the inferior trunk. And if the inferior trunk is compressed, what syndrome will you get? What kind of a paralysis you will see?
Clumkey.
Clumkey paralysis. Yes, you will have a clumkey paralysis because the lower part is supplying mostly distal limbs, right? The distal part of the limbs, right? No.
Yeah.
You have the roots C5, C6, C7, C8, and T1. If the upper roots are compressed or damaged, you will have more proximal symptoms. If the distal roots are damaged, you will have more distal symptoms, right?
Yeah.
So in the clumkey paralysis, symptoms are more distal in the limb, mainly the hands of the patient, right? So they will have a total claw of the hand. Okay.
Yeah.
That was again the feature of a Pankos tumor. Okay. So patient will be having a pain leading to the axilla, shoulders. Patient will be having this clumkey kind of paralysis or weakness of the upper limb. If along with this upper limb symptom, patient is also getting a supravena cava syndrome, only think about the Pankos tumor, not any other tumor of the mediastinum. Okay.
Yes.
So that was about the Pankos tumor. Any doubt? Please ask. Anyone?
No, thank you.
Thank you.
Okay, so we are done with the pathology now, and finally let's start the pharmacology. So first we have the H1 blockers. Now tell me, where does the H1 receptors found and where does the H2 receptors are found?
H1 is present in mast cells and in the brain, and H2 is present in the
H1 are not on the mast cells, but not on the mast cells, of course. Mast cells releasing the histamine, right? Not the receptors.
Yeah. On the nerves, right?
Lungs, mainly, right? On the lungs, on the brain, in the brain. Remember the chemotherapy at this what we will call it the vomiting center. It has receptors for the histamine, remember?
Yes.
So the vomiting center has a H1 receptor, lungs has a H1 receptor. And what about your GI system? H1 or H2?
H2.
H2. And how does this H1 work? What kind of this secondary messenger is available there?
IP3 dead.
For H1 you will be having a
GQ.
GQ. And for H2?
GS.
GS.
Okay. Yeah. So GS for cyclic AMP and GQ for IP3 DHG, remember? And
yes.
if you forget this, so you just either need to remember either the GQ GS or the H1 H2, because whenever you have a histamine in the lungs, it will always cause a bronchospasm, and that can be happen by small muscle contractions, right?
Yes.
And IP3 DHG system can cause these smooth muscle contractions, right?
Yes.
So that's how you know that in the lungs, because the contraction is happening, there must be a GQ subtype present, and it is the H1 now. Okay. So again, think that's how you can remember where the H1 is found and where the H2 is found, right?
Yes.
Now you have two type of blockers: the first generation blocker and the second generation blocker. First generation one can easily cross the blood-brain barrier, while second generations cannot cross the blood-brain barrier. So the first generation can act on the brain as well as on the lungs. So you can use these as the allergy, of course, for the motion sickness and for the sleep aid, because all of them can cause the hypersomnia, somnolence, sedation, right? Now, because they're acting on your brain, okay, and making a patient very sleepy and sedative, these drugs are contraindicated in the old age. Okay.
Yeah.
Okay, so these drugs are contraindicated in the old age. Apart from that, they also have an ability to block the muscarinic receptors as well as the alpha receptors. Now, because they're blocking the muscarinic receptors, If I give this to a patient, can it act on my eye and increase the intraarticular pressure there? No.
Yeah.
You require the muscarinic receptors to for the increase in your this what do you call it? What kind of flow is there? The canal of Schlem, remember?
Canal of Schlemm's increased flow.
Yeah, the canal of Schlem. Yeah. So you will have an increased drainage of the fluid if you activate the receptors, right? Because of a constriction of these muscles, the pupillary constrictors, right?
Yeah.
Okay, so because you're inhibiting the muscarinic receptors there, that can cause the increase in the IOP, and that's again a reason why why these drugs are contraindicated. And because they're inhibiting the alpha receptors, they can again cause the postural hypotension. So again, reason for the contraindication. So because of the sedation, anti-muscarinic activity, and anti-alpha activity, these drugs are not given to a old age patient. But for the allergy, what drugs you can give are the second generation histamine blockers, because they cannot cross the blood-brain barrier, and that's why they do not have any brain symptom, any CNS symptom. That means no sedation. So you will use these drugs only for the allergy, not for the motion sickness, not for the sleep aid. Okay. For the first generation, you have the diphenhydramine, dimenhydrinate, chlorpheniramine, okay, doxylamine, okay, and the promethazine. Okay, these are the agents for the first generation blocker. For second generation, you always have the adine in them, the loratadine, okay, foxfenadine. And what about the S2 blockers? Any name?
Cimetidine, ranitidine, famotidine.
Yeah, they have the tidine in it, right? And these drugs have the adine in it. Okay, so A or I is very much important to differentiate between these two. Okay. So any doubt on the blockers?
Do we
No,
need
thank you.
to remember drug names?
See, diphenhydramine must remember thing. Okay, but you can just look at them, the N and I, if you have this. Of course, you have to remember the drug names because they won't give you a first generation blocker, second generation blocker. Okay, they will just give you this drug name and they will ask you function of that, right? Or they will give you a patient for allergy or something like that, and they will ask you what drug could be given. So, of course, you have to remember the name.
Okay.
But the easy way to remember is by just looking at EN and IN. Okay, and for the first generation, for the H1 blocker, adine. For the S2 blocker, tidine, the ranitidine, famotidine, right? So again, this will help you remembering easily. Okay.
Thank you. Yeah.
Okay. Wait a second. Sure. So now the other agent you have is the guaifenesin. Okay, and this is an expectorant. That means it causes thinning of the respiratory secretions. Whenever this patient is having a very thick secretion, thick mucus pluggings, this drug will help the patient. Okay, please note it does not suppresses the cough reflex. Cough will be there, but the fluid, which was very thickened initially, now it become very much thin. Now, similar name with the guanfacine, this guanfenesin, you have one more drug that might get you confused. And if anyone remember the name, the alpha blocker, sorry, alpha agonist, not a blocker. Remember? I accidentally said that name
Guanfacine?
previously, if anyone noticed. Yeah. What name? The guanfacine, yes. Yeah. I've accidentally said it then before, right? The guanfacine. So guanfacine, remember for the alpha, guaifenesin, okay, it is for the this thinning of the secretions, okay? Don't get confused between the two. They have both very similar name, guanfacine, guanfenesin, right? And I think one more drug is there in the antifungal chapter, which go with a similar name.
Griseofulvin.
The griseofulvin, yes. Okay, so these three They always get me confused many times. So, be careful. Okay. The graciofulvin could be there, guanfacine could be there, and guanfacine could be there. Okay. These 3 drugs. Okay.
Another guanethidine.
Lots are there. Okay. It has T, so, somewhat help in differentiating T and not T. But yeah, the guanfacine and guanfacine, got me confused many times. So be careful in these 2 especially. Okay.
Okay.
Okay. Other drug you have is the N-acetylcysteine. I myself has many uses it, many times. It is a mucolytic. It liquefies your secretions. Okay. So again, it can work as an expectorant sometimes. So, somewhat like the expectorant, but not the expectorant, of course. So it will causing a liquefaction of the mucus, thinning the mucus secretions, mostly used by the COPD patients and cystic fibrosis patients. Okay, how does it do it? It is by disrupting the disulfide bond between the particles in the mucus. Okay. And again, I told you one more scenario where you have, this drug, the N-acetylcysteine, can also cause a replenishment of the glutathione. Remember?
Aspirin.
N-acetylcysteine. Yeah.
Yeah.
So this drug can also be used for the acetaminophen overdose, because in case of acetaminophen overdose, all of the glutathione in the body get utilized. You have a deficiency of that. To fight the active oxygen species, you require more glutathione, and that could be replenished by giving the patient N-acetylcysteine. So this drug can also be given in case of acetaminophen overdose. Okay.
Okay.
Okay. Yeah. So other drug you have is the dextromethorphan, and this is the cough suppressing agent, antitussive we call it. Okay. And this drug basically act on the NDMA receptor and block the NDMA receptors. Okay. Other than the NDMA blocking property, it has also mild opioid properties also. Okay. So mild opioid properties and having this NDMA antagonist properties. Okay. So they basically suppresses the cough. Okay. And because they have this mild opioid properties, if they're given in a very high dose, it can cause constipation. But in normal dose, it cannot cause the constipation. Please note this condition also. Okay. At normal doses, it cannot cause the constipation. But if you give this like in a very high dose, just like the opioids, it can again cause the constipation in the patient. And if the overdose is given, the naloxone could be given for the treatment of this overdose. And if you guys remember from the serotonin syndrome, the dextromethorphan can also cause the serotonin syndrome, right?
Yeah.
Okay, so remember this thing also about the dextromethorphan. And does anyone remember any other NDMA receptor antagonist? You guys have woke up, right? Not sleeping?
Ketamine. Ketamine.
Yeah, the ketamine. Ketamine. Any one more? Any drug of abuse? Drug of abuse. On try. Yeah.
Codeine.
14. I'm asking about a drug for abuse. And in drug intoxication chapter in the psychiatry, we have discussed one drug that is a receptor inhibitor of the NDMA. PCP.
Phencyclidine.
Exactly. Okay, phencyclidine, remember this drug also. So they all are the inhibitors of the NDMA, right?
Yeah.
Okay, so that was about the dextromethorphan, which is basically an NDMA receptor antagonist, as well as the opioid agonist. Over-intoxication, give the patient naloxone. It has very mild symptoms of this, the mild effects of the opioid. So it at normal dosage won't cause any kind of a constipation, right? But at higher doses, it can cause the constipation even. Now, other drugs you have is the pseudoephedrine or the phenylephrine, and we have discussed these drugs already. In the general pharma part, I've told you that these drugs are the purely alpha adrenergic agonist. So because they're agonist, they will cause a vasoconstriction. And if you take them intranasally, They can cause a vasoconstriction in your nose and can relieve from the nasal congestion, right?
Yeah.
So these drugs will be useful for the nasal decongestant as right, and they can also open the obstructive Eustachian tube. Okay, but tolerance is a very problem with these drugs. Remember, after some time, okay, the tolerance will be developed. The patient will get a tachyphylaxis, and as a result, after 4 or 6 days, the patient has to increase the dose of these agents, right? And he will keep on increasing the dose of these agents, and finally he will develop the rebound congestion. Remember?
Yes, yes.
Other than that, because they are seen as stimulants, they can also cause the anxiety, especially pseudoephedrine. Okay. Just give me a second. I think there's one more concept here. Remember the drug ephedrine?
Yeah.
What does this drug do? Ephedrine.
Anesthetic drugs.
The mechanism of
Bronchodilator.
action. The action of the drug ephedrine. How does this drug work? What is the function of this drug?
It's a bronchodilator.
Not a bronchodilator. See this pseudoephedrine? It is made up by the ephedrine. Okay. Kind of a variant of this that ephedrine. So now tell me, what does this ephedrine do? In a general pharma, we have discussed about this ephedrine. Indirect sympathomimetic, causes the increase in the release of non-epinephrine and epinephrine. And a variant of that drug, which is pseudoephedrine, it will be used as a nasal decongestant. Okay. Well, this phenylephrine, it will be directly acting on the alpha receptors and causing activation of them, right? So don't forget. Now you have the drugs for the pulmonary hypertension. I've told you 3 drugs: endothelin inhibitors, which are the bosentan, remember?
Yes.
So that inhibits the endothelin, because in case of pulmonary hypertension, endothelin will be increasing and NO will be decreasing, as well as the prostacyclins will be decreasing. So you need to raise the prostacyclin, you need to raise the NO, and you need to decrease the endothelin. So the first one is the endothelin inhibitor, which is a bosentan. Okay. Second one is the PDE5 inhibitors, like the sildenafil, for example. Okay. And contraindications of this drug, you already know. If you're taking any nitrite or any other vasodilatory agent, you cannot use this drug, right? Because it will cause a profound hypotension in the patient. Remember?
Yes.
Remember?
Yeah.
Yeah.
Okay. Finally, you have the prostacyclin agents, analogs, and these are the apaprostenol, okay, or the iloprost. Okay, so these 2 drugs, they have prost in their name. Prost mean analogs of the prostaglandins. Okay, so these are the prostacyclin analogs. Okay, PGI2. And does anyone remember any other function of this prostacyclin? Function of prostacyclin?
Open the patent ductus arteriosus.
That was the prostaglandins, not the cyclin. Function of prostacyclin. Platelet inhibition. Okay, platelet inhibition. They inhibit the platelet aggregation, and again, that's why you can other use of these agents. Okay, to inhibit the platelet aggregation. Very important. Side effects will be the flushing and the jaw pain. Okay, for a sildenafil, you will get a blue tinted vision. Remember? Hello.
Could you repeat?
For a sildenafil, you also have a blue tinted vision. Remember? In the eyes, you have a bluish vision in the eye, right?
Yeah.
Side effect for the sildenafil. Okay, remember that. And hypotension again is a other side effect. For the bosentan, you will have a hepatotoxicity. Okay. Now you have the drugs for the asthma. Okay. Whenever you encounter a patient having an acute asthma attack, you have to give a patient first bronchodilatory agents. You have to relieve the symptoms first. And then you have to treat the inflammation of the patient. Okay. So for the asthma, the two drugs will be given. One are the bronchodilatory agents, and second one are the inflammation inhibitory agents, right? Or anti-inflammatory agents. Okay. So the first one are the beta-2 agonist, and these are the widely used drugs for the asthma treatment. You have a short-acting, you have a long-acting. Short-acting ones will be used in the acute cases when a patient got an acute attack of the asthma. Okay, and they include the albuterol. Okay, A, the first letter of alphabet, that means a very short-acting. While the other, the salmeterol and the formoterol, they are very long-acting agent, and that's why they are useful for the prophylaxis to prevent the further attacks. Okay. But and because these agents are beta-2 agonist, if you give these agents in a normal dose, they won't do anything, but just a vasodilation. But at a very higher dose, they can go systemically also, and they can cause a tremors and arrhythmia also, right?
Yeah.
So these are side effects of the beta-2 agonist. Second one are the inhaled corticosteroids, and they are useful for the inhibition of inflammation. Okay, fluticasone and the budesonide, they are the two drugs. Okay, which you use in the asthma. Okay, and we have to be very careful while using these drugs because they are suppressing your immunity, and mainly in the oral area, they will suppress the immunity. They will cause a lymphocytic and a neutrophil dysfunction. So lymphocytic mainly. So they can also cause the growth of candida in your mouth, and that is known as the oral thrush. Okay, so while using these drugs, you have to do the gargles. Okay, you have to use a spacer also. Okay, you have to drink a lot of water after using these drugs. Very important. So if you encounter a patient having asthma and now he's having some whitish lesions in the mouth that are easily scrapable, okay, you will think about the oral thrush due to the corticosteroid use. Okay.
Yes.
And these are the first line therapy for
Okay.
the asthma treatment. Okay. Other drugs are the muscarinic antagonist because muscarinic receptors in the respiratory system, they will cause a bronchoconstriction, right? By IP3DH system.
Yeah.
Remember M3 receptors? So you will give the patient M3 blockers. These are the tiotropium bromide and the ipratropium bromide. Okay, and they inhibit the muscarinic receptors, preventing the bronchoconstriction. Mainly use these drugs for the COPD. Okay, and the tiotropium is the longer acting agents among these. Okay, very important. So basically, they reverse the action of vagus nerve. Can I say that?
Right.
Because ultimately, vagus nerve is acting through the muscarinic receptors. They're releasing, the vagus nerve is releasing all this acetylcholine, and that's why you're having this the release of acid in the stomach and then the vasoconstriction, right?
Yes.
So the other way I can say that these agents reverse the effect of vagus nerve or reactions of vagus nerve. Okay. So step one can also, ask you in this way that what is the function of these drugs. So the function is to reverse the effect of vagus nerves. Then you have anti-leukotrienes because I told you leukotrienes causes Just give me a second again.